Good morning. My name is Samille Jackson, and I am the Maternal and Child Health Coordinator with the Alabama Department of Public Health. To kick off this summit, we will have greetings from Dr. Scott Harris, State Health Officer of the Alabama Department of Public Health, Dr. Regina Traylor, the Executive Director of the Gift of Life Foundation, Incorporated, and Mr. Ricky Green, the CEO and Project Director of Birmingham Healthy Start Plus.
Good morning, everybody. Thanks so much for joining us today. My name is Scott Harris with ADPH, and we're very honored and happy to have you with us today. We're going to have a terrific day kicking off our 2023 State of Alabama Infant Mortality Summit. This is the fifth summit that we've hosted, and since the beginning, we've had our partners from Gift of Life Foundation and Birmingham Healthy Start Plus. We're so happy to have them with us today and appreciate their help as our co-hosts. The theme for our meeting today is empowering communities to transform maternal child health. And we have some wonderful speakers and wonderful topics that you're going to hear from today. I don't have to tell you that infant mortality is really a crisis in Alabama, and it's not a crisis that's new in the making. It's something that we have dealt with for a very long time. The infant mortality rate, most recently in Alabama from 2021 is our most recent year with statistics, is about 7.6 deaths per 1,000 live births. That's not a great number. That compares to about 5.5 deaths per 1,000 live births for the nation as a whole. And the real story there is the racial disparity that we see. Black babies in Alabama are more than twice as likely to die in that first year of life as compared with white babies. And that's a number that we think is tragic and ought to be unacceptable. And we appreciate all the work that you all are doing to address that. We're going to talk about a number of things that play into that. Family support, we know, is such an important part and really a determinant of infant mortality. We know that when children are raised in a father absent home, infant mortality is twice as likely to occur. We know that there's a four times the risk of poverty in a father absent home, and we know that children raised in that environment are 7 times more likely to become pregnant as teenagers. And so we want to stress the importance of family support in addressing that situation. But we have a number of highlights that you're going to hear about today throughout the day. We're working with other state agencies and educational institutions and nonprofits, healthcare providers, community organizations on so many different things. ADPH has been able to distribute more than 400 cribs to low-income families this year who weren't able to get those on their own. We continue to have our perinatal nurses stationed around the state at our highest volume delivering hospitals, helping to learn about and educate others about the infant mortality issue and working with folks at the local level to address those issues there. We're partnering with the Alabama Maternal Health Task Force and with March of Dimes on maternal health outcomes as well. Another aspect of this issue of infant mortality. The governor's initiative to reduce infant mortality continues, run through not only our department, but several of our sister agencies, health and human service agencies in state government as well, working on things like safe sleep education, home nurse visitation projects, and so on. So I would ask you, if you get a chance, to take a look at the Alabama Perinatal Health Act Annual Progress Report for 2022 and our plan for 2023. We're very proud of the work that we're doing here and hope you'll have an opportunity to take a look at that. So the purpose of our summit here today is to provide an opportunity to learn more about the societal and environmental factors that impact both maternal mortality and infant mortality. We want to present an overview for you of all the efforts that are underway now and help you to sort of better understand how these problems impact our community as a whole, how we can partner together with each other and with others in the community to continue to try to provide the best possible outcome for our moms and babies here in Alabama. So thanks again for joining us. Again, we thank our partners, the Gift of Life Foundation and Birmingham Healthy Start Plus. At this time, I'm going to pass the mic over to Dr. Regina Traylor.
Thank you, Dr. Harris.
Thank you. Thank you, Dr. Harris. Good morning, everyone. As stated, I am Regina Traylor, and I'm the Executive Director for the Gift of Life Foundation. Welcome to the Infant Mortality Summit. We're really pleased that so many of you are participating today in the summit. For more than 30 years, the mission of Gift of Life Foundation has focused on building healthier communities, one family at a time. But I believe each of us can say and know that the loss of one infant is one too many. So it's awesome to see so many partners, so many stakeholders, so many community participants out today. This is very encouraging as we continue this journey to reduce infant mortality. I want to thank each one of you for participating, And I know that today you're going to receive some awesome information from a multitude of speakers. And I believe the opportunity today will allow us to further enrich our awareness and our understanding of infant mortality. Again, thank you and welcome to the Infant Mortality Summit.
Thank you, Dr. Traylor. Good morning, Mr. Green.
Good morning. Can you all hear me?
We can.
Good. Good morning. I would like to again welcome everyone to our fifth Infant Mortality Awareness Summit. I am Ricky Green, CEO of Birmingham Health Start Plus, the agency and the director of Birmingham Health Start Plus federal program. For 32 years, Birmingham Health Start Plus has provided MCH supported services to program participants, it's pregnant, non-pregnant women, and to fathers through our fatherhood engagement program, with an aim to eliminate disparities in perinatal health, reduce infant mortality, and now to address issues and hopefully reduce maternal mortality. We also, in addition to the routine services that we provide, home visiting and other support services, we do provide doula support services and mental health and behavioral health services. By the way, on the slide, we had mentioned that our classes were temporary by Zoom, but they are all full-blown services. So I just did want to mention that. Birmingham Health Start Plus continues to be very active in the infant mortality review as a member of the Infant Mortality Review Committee, the Maternal Mortality Review Committee, the Alabama State and other local maternal mortality task force. I think you are going to be enriched with a lot of information today, and we hope that that will be meaningful for you as you move forward with your child, with your opportunities to address the issues of infant mortality and maternal mortality. Thank you again for joining us, and enjoy the summit.
Thank you, Mr. Green. Thank you again to Dr. Harris, Dr. Traylor, and Mr. Green for their support of the planning and hosting of this summit each year. We are so glad that all of you have joined us today, and we are so grateful for your support as we continue our endeavors to reduce infant mortality. Our first speaker for today is Dr. Candace Knight. Dr. Knight is an associate professor at the University of Alabama at Birmingham School of Nursing. She is also the director of the Nurse Family Partnership of Central Alabama and teaches maternal child health nursing in the undergraduate and master's programs. She has over 25 years of experience in this field, and her areas of expertise and research include perinatal stress and its impact on pregnancy and birth outcomes, as well as social determinants of health. We welcome you, Dr. Knight.
Thank you, Samille. Can everybody hear me okay? Samille, can you hear me? Is my audio good?
Yes, ma'am.
Fantastic. Okay, well, I'm gonna share my screen and You guys let me know. Can you see my
Yes.
slides still?
Yes.
Fantastic. Okay. Well, I will go ahead and just jump in here. I just appreciate so much the opportunity and the privilege to be with you guys this morning. This is a topic that is near and dear to my heart, and you'll learn a little more about why in the next slides. But again, as Samille said, I am the director of our Nurse Family Partnership of Central Alabama, which is a nurse home visitation program. Dr. Harris mentioned, Dr. Traylor also directs a program for Nurse Family Partnership, but we feel like it's one of the solutions to the problems that we see in our state on infant mortality and maternal mortality. So you'll hear a little bit about that as I go through my slides today. And the pictures that you will see, many of them are from our beautiful clients. I'm not saying that all of those are adolescent moms, because my topic today is adolescent pregnancy, but they are pictures from our beautiful clients. So with that, I will just go ahead and get started. So no potential conflict of interest for me today, but again, vested interest because of my life story and just the appreciation that I have for these young girls who have worked so hard to raise their babies. So objectives today, identify trends in adolescent pregnancy in Alabama and the United States. And so overall, those are going to be really positive trends, and it's going to be good news. We're going to talk about the risk factors for poor outcomes in adolescent pregnancy, with the understanding that not all adolescent pregnancies end in poor outcomes. And then we're going to finally talk about some strategies for supporting adolescents or teens in pregnancy and parenting, hoping to really optimize their outcomes. And so I hope you guys will bear with me. I'm going to probably flip back and forth between teens and adolescents, but I'm meaning the same thing. And so the first thing I want to do here is really get to know who actually is here. And so Samille or I'm not sure who was going to do it. Can you launch this poll for me? I really just want to know, what is your primary role? Are you a nurse, a physician, social worker, home visitor, administrator? What's your primary role? Looks like both polls pulled up together. So I guess you can go ahead and answer both, and then we'll talk about them as we get through it. I'll give you just a few minutes. It's early. We've got to have audience participation. You know, make sure you got your cup of coffee and you're ready to go. I want to make sure you're awake. I'm awake. Got some responses yet, Samille? How are we looking?
Yes, we are about half and half with nurses and social workers, and then we have a few home visitors and administrators and a couple of physicians.
Okay. Did the second poll also launch at the same time?
Yes,
on my screen? Okay.
Yes, both questions, all three questions actually.
Okay.
And we do have mostly the friend and coworker for that second question, and yeah.
Okay. Thank you. All right. Well, we'll move on then. So welcome to my nurse colleagues and other folks who are here, physicians and social workers. We couldn't do the work that I do without social work and all the other people. So we're going to talk a good bit today about really the net of support that is required for these moms. So you guys are that net, and I really appreciate the work that you're doing. All right. So first of all, let's define adolescent pregnancy. So adolescent pregnancy of a girl between the ages, sorry, that slide didn't update. Someone who is 19 or younger. And so there are three different categories of adolescent pregnancy. There's early adolescent pregnancy, which is 10 to 14. And then there's middle adolescent pregnancy, which is 15 to 17, and then late adolescence, which is those ladies who are 18 and 19 years old. And so you can see on this slide that between 1970 and 2020, we have been on a major downhill slide for the rates of adolescent pregnancy, which is great news. You can see way back in 1970, we were somewhere around 23 or 24% of all of births were to teenage moms. And right now in the United States, we're down to 4.4%. Alabama, as with a lot of things, unfortunately, is a little higher here than the rest of the country. So 6.7 in 2020. So that poll already came up, but I was interested to see how many of you know someone, or actually really not even how many of you, but who do you know who's been impacted by adolescent pregnancy? You probably all know someone whose life has been touched by adolescent pregnancy, whether it was you, whether it was your sister, your brother, your mom. You may have had an aunt or a cousin. You could have had, a neighbor, coworker, or a friend. And I would say when I answer that question, I know I have a lot of those relationships that have been touched by adolescent pregnancy. And so it's one of the reasons that that propelled me to do the work that I've done over my career is just knowing so many people who have been touched by adolescent pregnancy. So I want to talk a little bit about those moms that I know. And not all of the pictures on this screen were pregnant adolescents or were pregnant teenagers. But I do want to share some of the stories that I have heard over the course of my lifetime with adolescent pregnancy. Most recently, I'll start with the most recent, and it really was kind of timely because I was preparing these slides, and I got a call from a young girl who was pregnant for the second time. She had an 8-month-old, and she was 4 months pregnant, and she was desperate. She was about to get kicked out of the place where she was living and had nowhere to go. And she was desperate for support. And as we, talked about her story, we learned that she really had a breakdown of her family. She was no longer living with her family of origin. She had had a series of guardians over the course of her lifetime. And at this point, she was living with the family of the father of the baby. And she really was desperate. But the thing that really struck me was that she was reaching out for help. She knew she needed support, and she was reaching out. She was going to do whatever she could to get stability, to find stability. And the other thing that I thought was really beautiful about her story was that she was determined and she had a plan. For so many pregnant teens, this pregnancy is really something that may give them hope and requires a lot of courage. So you'll see the title of my slide is Stories of Hope and Courage. But she had a plan. She knew she was staying in school. She was doing what she had to do to stay in school. She knew what she was going to do in her career after she graduated from high school, and she was this close. And so I have no doubt, I have complete faith that this young woman will do exactly what she said she was going to do, and she's going to be a great mom to the 2 babies that she has. As I did my research for my dissertation, it's been 10 years ago now. I talked to a lot of teen moms, a lot of girls who were pregnant at the time, and heard a lot of similar stories. I titled my dissertation "Hard on Your Heart" because that was kind of the theme that I heard from a lot of these girls, is that while the pregnancy itself physically, was a little challenge, what was the most difficult thing was that it was really hard on their heart. I don't know if what your opinion is of pregnant adolescents, but they get a lot of disrespect. They get called a lot of names. They get cast aside and discounted. They're told things like, well, you've ruined your life. There's just no hope now. Look what you've done. You've got to pay for your consequence. You've got to pay the consequences of your actions. And in some families, there's a lot of tough love kind of thing going on with those types of responses. But often I heard from these young women stories of, families who said, well, you have to keep the baby, because you're gonna deal with this decision that you made. And so there was not an option for them to give a baby up for adoption. And then I heard stories from other girls whose families were ashamed and embarrassed, and really were trying to even force them into having an abortion. And so, at this age, there's the locus of control, or the power that these girls have in their lives is very limited. They're dependent on their families. And yes, they have made a very critical decision and that will impact the trajectory of their lives. But it doesn't have to be a decision that, as so many say, ruins their lives. Other stories, I talked to a lot of pregnant teenagers, and I had one tell me a story about her prenatal care experience. And she happened to be in group prenatal care, which is an amazing thing. And hopefully somebody else today is going to talk about that. But she was sitting in this group prenatal care, and the way that she was being spoken to was as a child. And she was there. She was always there. She was consistent with her appointments. She was doing everything that she could to take care of her baby. She's taking her prenatal vitamins. She's not drinking. She's not smoking. She's doing everything she can to have a healthy pregnancy and a healthy baby. And she noticed that some of the other adults were speaking to another mom in that group with a lot more respect. And that particular mom had a history of lots of other decisions and she wasn't currently making good choices for her pregnancy. She was continuing to do the things that, drinking and smoking and the things that not necessarily taking care of her body and her baby the way that this teenager was. And she said, it just struck me that I'm being disrespected, even though I'm really trying to do the best for me and for my baby. And so, I want to encourage all of us to remember that these young ladies, while it may not be the best time in their lives for them to become a mother, it may not be the easiest time in their lives for them to become a mother, these young girls are still deserving of respect and dignity, just like anybody who walks through our clinics or our programs. These folks are really trying to do the best they can for their families. And then, lastly, I want to draw your attention to the picture on the right, the young girl and the young baby. And this is the reason that this work is so important to me. That's my mom, and that's me. Sorry, I didn't have any clothes on, but we didn't have very many pictures of us because we were dirt poor and didn't really have a camera, or not really. We didn't have a camera, so somebody else took this picture of my mom and me. And my mom was 16 when she got pregnant and when she had me. And so we grew up together. And I will tell you that our story has a great ending. My mom went on to become a nurse, and she's my hero. She's my inspiration. She went back to graduate school after I kind of stepped away from graduate school, and she got her nurse practitioner license. And so she's an oncology nurse practitioner. And there are probably a lot of people around the state who recognize my mom as their angel, because I can't go anywhere with her in our community. And somebody stops her and says, "Oh my goodness, I'm just so thankful that you were there for my family when my dad or my mom had cancer," or so she's my hero. So we are proof that not all adolescent pregnancies end in disaster or poor outcomes. Not to say that any of them really are easy, because we did do a lot of growing up together. And but I just wanted to share some of these experiences and hope that you understand that that when a girl finds out that she's pregnant, when she's 16, when she's 17, when she's 14, that, it's rarely intended, and we'll talk about intendedness a little later, but it's rarely intended, but sometimes it gives these girls who typically, very often, and we'll talk about social determinants again in a little bit, but very often these families have had a breakdown of some sort, and there's not a lot of family support there. There's something that's gone awry. That was the case in our family. My grandparents had divorced, and so there was just not a lot of focus on that teenager in the family. And so that's a pretty common experience with the girls that I talk to. So I hope that you'll kind of remember these girls and their stories as we continue to progress and talk about this as we go on through the day or through the morning. All right. Hopefully you can see this map. And I want you to look at this map, and this is the rate. So all of these, not all, almost all of my charts and graphs and maps today will be from the Alabama Vital Statistics Report of 2020. And so this map is the teen birth rate. So per 1,000 teenagers, this is the birth rate in each county. So everybody take a second and find your county, wherever you are. And then take a second to look at the really dark emerald green that matches my shirt. Those rates are 19.6 and above. The blue is 16.1 to 19.5. Gets a little better in the gray. It's 12 to 16. And then the light green is under 12. And so we're going to talk about this map in a little more detail later, but I wanted you to just get an overview of where teen pregnancy is most prevalent in our state. And then we'll talk about some of those reasons why. I sit in Jefferson County for my work, and the rate there is 10.1 per 1,000 teens. And then I live in St. Clair County. So both of those counties are light green, but you can see Pickens County at 20, Greene County at 30. Yeah, there's always a caveat with these rates, especially when numbers are small. And so I don't know if my data analyst is still on the call, but Taishela always says, but when numbers are small, you want to be cautious about drawing inferences. But certainly you'll see that for the state that these numbers aren't that small. So this graphic, and so for all of you who are data nerds, I have lots of charts and graphs today, but I'm going to try to give it some stories. This one in particular is from the infant mortality report, the most recent infant mortality report. So you'll see this, this is a percent instead of a rate. So a little bit different than the former screen, but this is percent of births to teenagers. So ages 10 to 19. From 2012 to 2021. So you can see that trend. You can see it's a wonderful trend that percentage is dropping. And right now, in 2021, the most recent data, it was 6.4%. And so that's a wonderful thing. We're continuing to see this number fall. And hopefully we will continue to see that fall even further so that we are at least, at the national level, which again was like 4.4. Okay, I'm going to spend some time here. I know this is busy and there's a lot here, but I want to highlight a particular column here. So we're talking about the scope of adolescent pregnancy and how, really how prevalent is it in our state. So this is again from the Vital Statistics Report. And so I've got a link to it in my references if you guys want, or you can just Google Alabama Vital Statistics 2020, and it's an amazing report. But this is the estimated pregnancies, pregnancy rates, and outcomes by race and age for 2020 in Alabama. So if you go along the top and you see the age group of the female, go almost all the way over to the right where you see 10 to 19. And then if you drop down, can y'all see my cursor if I have it?
Yes,
You
can
can
you make that graph full screen so that we can see it?
see.
Right now we can see your upcoming slide, so it's not,
Oh no.
yes.
I wish you'd told me that before.
I tried to check you.
Let me do a new share. Let me see.
It's just you're just in presenter mode instead of, there you go.
Okay.
Thank you.
Yeah. Thank you, Samille. All right, so you can see this column here, this 10 to 19. That's where we're going to spend our focus here for a second. And so you can see, and so this is the year of 2020, and this was, in the middle of the pandemic, right? We have 5,296 estimated pregnancies for girls between the ages of 10 and 19. And then if you drop down to here, we have of those, 3,837 of those ended or resulted in live births. And then we're going to drop down again, and 629 of those total 5,296 ended in abortion. And then another 831 of those births or those pregnancies ended in an estimated fetal loss. So that's a pretty big number. That's to me, when you talk about the scope, that's still a lot of pregnancies across our state. And we had a total of 77,385 pregnancies in 2020 for our state, and over 5,000 of those were to young women between the ages of 10 and 19. So you can see the breakdown though here of that early, middle, and late adolescence. So fortunately, only 88 of them were between the ages of 10 and 14. And then the bulk of them, almost 4,000, were between the ages of 18 and 19. And I will tell you that it was Nurse Family Partnership of Central Alabama, when we started, the median age group of the women and the families that we took care of was around 19. For a long time, it's a little higher now, a little older. But when we started, it was around 19. All right. So let's talk about abortion. And I want to just take a second and say that there's no political intent here. I'm not trying to change anyone's mind about anything. But there's a reality here that, as you saw on the last slide, 629 of those pregnancies in 2020 ended in abortion. And can anybody tell me what happened on June 24th of 2022?
I'm checking the Q&A for an answer.
Nobody's willing to say? Nobody remembers? I remember this.
Roe versus Wade overturned.
That's right. That's right. So that made abortion no longer legal, particularly in the state of Alabama. And so that means that those 629, 630 or so girls who were pregnant in 2020 need more support. Those young women, that's not an option for them anymore. Those young women are going to have to make the choice to parent or to adopt. And so that's an important statistic. And what we know is that since we're going to have more young women who are giving birth, because abortion is no longer an option, and those families need our support. They need that safety net that we, as we who deliver social services, healthcare, are going to have to provide. So let's talk about pregnancy intendedness. Depending on how you define it and what particular source you look at, you will find that 46 to 49% of all pregnancies in the United States are unintended. I wish I could see you because I like to poll the audience, and this is frustrating for me not to be able to see all of your faces. But I wish I could ask you to have a show of hands. You might not raise your hand of how many of you had a pregnancy that was unintended. Doesn't mean that you don't love that child. It just maybe means that it didn't happen at exactly the time that was perfect for you.
They are raising their hands. Can you see
I
that?
bet I can't see it.
Yes.
Yeah.
It's going and going.
I will
over
raise my hand too.
50 people.
I also will raise my hand, even as a labor and delivery nurse. I had one of those pregnancies, and I know how it happens, right? We all know how it happens. And that was actually one of the things that came out of my dissertation research when talking to these young girls. They know the risk. It's not it's not one of those things where they don't know. It's not one of those things that we didn't know where babies come from, right? That's something that we all learned a long time ago. So from that, I want you to kind of bear that in mind too as you work with pregnant adolescents. And then I want you to drop down to this next statistic. 82% of all teen pregnancies are unintended. So while they may know the risk, we also know that teenagers engage sometimes in risky behaviors because of their developmental stage. It's a normal thing for teenagers to kind of push the envelope a little bit. And you couple that with family structures, social structures that aren't supporting these teenagers, and not these teenagers don't have the appropriate boundaries and resiliency in their lives, then the risk for adolescent pregnancy really goes way up. You wonder sometimes about, okay, what about that other the rest of those girls who did intend to become pregnant? Remember that this age group goes all the way to 19. And so there are a lot of young girls who do intend to get pregnant, but I think gone are the days of those pregnancy packs and those things that we saw on MTV. But most of these girls, 82% of them, don't intend to get pregnant. And then when we're talking about abortion again, you will see that in 2020, that 12% of all of those pregnancies, I wrote down somewhere exactly how many, over 5,000 pregnancies, 12% of those ended in abortion in 2020. And so we know that we've got a lot of work to do to support these moms. And we're going to talk about prevention, don't worry. And then we're going to talk more about supporting these moms who do become pregnant, because that's often as healthcare providers and community service providers, that's often our first interaction with these young women, is when they become pregnant. Okay. I don't know if you guys saw this, and this shook me. This was actually August 24th. Alabama teen mother charged with capital murder for allegedly throwing her newborn in a trash compactor, a large trash compactor. And this baby did not survive. And again, this was one of those things that happened as I was preparing these slides. And so I feel like we have to talk about it. This particular, and I am in no way trying to demonize this woman or her family. But this was a situation where this family and this young girl needed more support. And how do we do that? How do we get to, she had prenatal care. Her family was aware that she was pregnant. This is not one of those situations where she hid the pregnancy. How do we, as healthcare providers and community service providers, give families like this support so that these tragedies don't occur? This one shook me. And so I hope that you will join me in rallying around these families to give them support so that they know that there's no shame in being an adolescent mother. And there's no shame in giving your baby up for adoption. I also have, so the other part of my story is that I have a brother who's adopted. And so I have seen the joy that he has brought to our family. So this brings me to prenatal care. So again, a lot of the time, the first time we have contact with these girls is during prenatal care. And so I wanted to break this down a little bit. So hopefully you guys can see this, and it's big because this is another one of those big charts. So this chart is about adequacy of prenatal care. And again, you can find this in the Alabama Vital Statistics report. But adequacy, so inadequate prenatal care is where we're going to focus. So this column over, let's see, over here. I'm trying to move my cursor to y'all's screen. Inadequate prenatal care is defined as prenatal care that began after 4 months gestation, or for a woman who received less than 50% of the recommended visits. So again, so we're going to focus here on the inadequate column, and then I want to look at the age brackets under 15 and 15 to 19. So you can see here and here. So we're going to just go all the way across. So so again, thankfully, we only had 50 of these who were under 15, and then 3,700, almost 4,000 between the ages of 15 and 19. But if you come over here, I want to show you that half of the girls who were under 15 had inadequate prenatal care. Anybody want to venture a guess? What was the reason for that?
Let's see. We're getting an responses. Shame. Pregnancy wasn't suspected, I see.
Yeah.
They hid it. They didn't tell anyone. They didn't know.
Yeah,
Yeah,
absolutely.
a lot of they didn't know, or they were hiding it, is what I see.
Yeah.
Fear.
Yeah, fear.
Access to care.
Yes,
Okay. Someone said they couldn't drive themselves, so transportation a couple of times.
right.
Okay.
Lots.
Thank you, all.
Yeah. I think those reasons are probably spot on. Fear of what their family or other folks are going to say, and then they're going to hide it as long as they can. And let me tell you, a teenager can hide a pregnancy, just like they can hide food in their room. They can hide a pregnancy for a long time. It's sometimes remarkable how long a girl can hide a pregnancy if she wants to. So that's probably, for this age group, probably one of the big reasons for inadequate care. And then if you look at that age group between 15 and 19, so again, that's 3,700 pregnancies, and 1,000 of them had inadequate prenatal care. Probably for some of the similar reasons, but I tend to think access is also an issue here. Transportation. I know that Regina and some of the others of you who do similar work know how just what a huge barrier transportation can be for our moms, and particularly our teen moms who don't necessarily have family who is willing and or able to take them to their appointments. There are some great resources around transportation. Kid One is an amazing resource, but it's not available everywhere in our state. And so we've still got some work to do here with adequacy of prenatal care, particularly with our teen moms. One of the things that I have seen that has been just really a remarkable resource, and I think it's growing in our state, is school-based clinics, school-based healthcare. I know here in Birmingham, Fairfield City Schools in particular, they've got a school-based clinic. So these young women can get healthcare right there at their school. The families of these girls can get healthcare right there at the school. And so that's a tremendous asset. So that's just one of the solutions. And so this particular slide really struck me as well. When you look at adequacy of prenatal care by race, we continue to see inequities, racial inequities in our state. You can see here in this under 15 age group, the girls who were white, there were 22 of them, 8 of them had inadequate prenatal care. When you look at this group of Black and other, over half of them had inadequate prenatal care. When you look at the older age group, the 15 to 19, you see that white teens had a rate of 24% inadequate prenatal care, while Black and other were at 30%. And again, this is, is this access? Is this fear, shame? We don't know, but it needs to change. We've got to do a better job getting these girls to care earlier, because what you'll see later is that they are at much higher risk for poor outcomes physically and socially as well. Checking my time. All right, so low birth weight. We can see here again that so we're gonna draw your eye to the percent of low weight births, again, in these young age groups. So if we're looking at under 15, 20% of them had low weight births. 15 to 17, 18 to 19, those are around 12%. So if you lump them all together, it's still going to be around 12%. So again, that's going to be a little higher. And Samille, were you trying to get my attention? Okay.
No, ma'am.
All right. So this is yet another outcome where we can improve with our adolescents. Okay, infant mortality. That's what brought us here today, as the focus is infant mortality. And so let's talk about this by age group. So when we look at this under 15 group, I want to stay over here in this total range, because again, these are small numbers. And so I know my data analyst is wagging her finger at me. These are small numbers. So we're going to be careful with the conclusions that we draw here. But you can see that the rate was 40 here for this group, but it was 2 babies. Okay, so that was 2 infant deaths for this group under 15. 15 to 17, there were 6 babies. And 18 to 19, there were 25. So in total, there were 33 cases of infant mortality in this age group between 10 and 19, or under 19. And that rate is 8.6, sorry. And you heard Dr. Harris say our state was 7.0 as a whole. So again, you can see that infant mortality is a bigger risk for our adolescent moms. And again, why we need to make sure that we're getting them to care early and we're surrounding them with the safety net of support. Excuse me. Okay, so let's shift a little bit as I shift in my seat and maybe talk about some of the reasons for these outcomes and these disparities. And so I've put these 2 maps side by side. And so the first one you've already seen, it's the rates of teen pregnancy in our state by county. And the one on the left, I pulled from the NIH, and it's the rates of poverty in our state by county. And then, as you can see, the darker blue colors are where there's the poverty level is the highest in our state in those counties. And as it gets lighter, poverty is less. And so you'll see the darker blue are the most impoverished counties in our state. And you can kind of draw some, you can kind of look back and forth between these maps and see that where there is more poverty, in a lot of these counties, there's also more adolescent pregnancy. So again, we're kind of connecting the dots here and seeing that where there's less support, because where we know that there's poverty, there's less support. We're seeing more adolescent pregnancy, and this map, you could probably layer several maps across here, including infant mortality, including preterm birth, and a lot of different things, and you would see similar outcomes. So they don't necessarily mirror each other, but there are a lot of similarities between the two. So let's talk a little bit about life course. If you've done work in maternal child health for any length of time, you've probably heard life course perspective. And there are things that when we talk about adolescent pregnancy, there are times when that falls outside of a normative life course trajectory. And times when it doesn't. There are cultures around the world where an adolescent pregnancy is really fairly normative. That's not the case here in the United States, and so it does fall outside of a typical life course trajectory for a typical U.S. teen. But there's some, subcultures within our nation and within our state where it's more prevalent, and so. What you will see is where we kind of veer off a typical life course or expected life course for our culture. That's going to cause these teens more stress. And so things that are going to impact your life course, obviously adolescent pregnancy will impact a person's life course trajectory. But so does poverty and socioeconomic status. We know that where there's more poverty, a young woman is more likely to become pregnant in adolescence. We also know that race has an impact. While there are more number of white teens that get pregnant and give birth in Alabama, the rate or the percentage of Black teens, Black and other adolescents is higher. And again, so we continue to see those inequities. I'm going to talk just a bit about health policy as we talk about life course and its impact on teen pregnancy. And you're probably going to hear a lot more of this, so I just made it one little bullet point because I'm hoping the rest of the speakers today are going to hit this kind of hard. This investment in women's health, healthy communities, and social conditions really have a profound impact on the life course of our young people. And I think we all can kind of get on board with these things are really important to invest our resources in. Women's health, we know that, that impacts the health of a pregnancy, and the health of a pregnancy impacts the health of a baby and that baby along their life course. And so really investing our resources, making sure all of our moms, whether they're teenagers, whether they're women of color, whether they're white, whether they live in rural or whether they live in urban environments, investing in their health and not just while they're pregnant is pivotal for our state and for our communities. Having those healthy communities, having places that are safe, having places where food is readily available. We know that those things really impact the health of our communities and of our nation. And then the social conditions, that social network, that web of support that our families need. When that is rich and that net is tight, we see families being more successful. And so it's just vital to the health of our state, to our teens, to our youth, that our health policy was really focused on these things. I would be remiss if I didn't talk a little bit about interpersonal impact. And so, you heard me talk in the beginning about the stories of these girls that I know who have been pregnant as teenagers. And very often what we see is that when there's interpersonal conflict within families, within even within their relationships. Pregnant adolescents are at greater risk to have intimate partner violence. So those interpersonal relationships are key. And we know that when a pregnant young girl has one person that she can count on, that supports her, that is that backup for her, she's going to do better. That was the case for my mom. My mom had that one person in her life. And she was able to finish school, and she was able to find childcare, and she was able to do the things that she needed to do to be successful in her life and to support me in being successful in my life. And so what are those resources? We talk about mental health, and that they're really having a crisis of mental health, particularly in our young girls. You will hear those statistics. I hear it daily that we are in a crisis, a mental health crisis for young girls. I have a teenage daughter right now, and so I hear it. She brings home these stories on a regular basis, and so we've got to again invest in those support systems for these young girls. And then I can't walk away from this presentation without telling you and making sure that we're all aware that high school students are still having sex. 38.4% nationally of all high school students. And I didn't say high school seniors. I didn't say juniors, all of them. Okay, so this is 9th through 12th grade. 38.4% of them report having sex. Okay. And so we can say that's probably a little higher because not all of them they're going to admit to it or fess up. And so that will bring me again back to when we talk about ways that we can impact this is family planning. So, but before we get there, I do want to talk a little bit about mental health and trauma. In the work that I do with home visiting, it is so frequent. And I won't say it's everybody, but it's so frequent to hear stories of trauma, particularly with young girls who are pregnant. And so those stories of trauma, a lot of these young girls have had experiences with the mental health care system. Some of them positive and some of them negative. But what we know is that the higher the ACEs score, so probably you guys all know that ACEs is the Adverse Childhood Experiences Scale. The higher the ACEs, and those measure things like, did you have a parent that went to jail? Did you have a parent who was involved in substance use and abuse? Those types of things. The higher those ACEs are, the more trauma, the more likely a young person is to become pregnant. And then we definitely see impact of mental health diagnosis. So when you have trauma, particularly in childhood, that is highly associated with mental health diagnoses, things like depression, anxiety, even bipolar. So we know that these young girls coming to us for prenatal care, for social support, for home visiting, when they're teenagers, they're probably bringing with them a history of trauma in their lives, and we've got to be able to point them to and connect them to the resources that they need to move forward in the healthiest way possible, so that they don't repeat the cycle of poverty and the cycle of trauma that has been perpetuated in their family. All right, let's talk about some physical risks to pregnant adolescents. You can see this is a lovely just picture of some of the physical risks to pregnant adolescents. They are at higher risk for preterm birth, low birth weight, those babies having low APGAR scores, preeclampsia and eclampsia. We see the youngest and the oldest moms have more risk, and so they're also higher risk for preterm premature rupture of membranes, anemia, sexually transmitted infection, and increased maternal mortality. So the younger the girl, the higher the risk, typically, for a lot of these things. And I already talked about the emotional risk. These girls typically are not celebrated in their pregnancy, like someone who was, 23, 24, and, had checked all the boxes of success in our society. And so she's coming to you with, a heavy laden heart, and also at a lot of risk, physical risk as well. We also know that, socially and economically, these girls have a lot of challenges ahead of them. But I find it interesting that when we look back at life course, the teen that is most challenged by pregnancy is often the teen where it's most unexpected. It's it most differs from her typical life course, the expected life course in her family, in her culture, and in her community. So if this girl lives in a family where her mother and her sister and her aunt all had adolescent pregnancies, it's going to be a lot more accepted, and she may have a lot more family support. If this young woman lives in a family where there's never been an adolescent pregnancy and the family is particularly embarrassed or ashamed, she may have less support, and there may be an attitude of punishment around this pregnancy. But the risks don't end with the teen, with that mom or with that father of the baby. To the child, there are also risks. The children of adolescent parents are less likely to complete high school. Their sons are 13% more likely to go to prison, and their daughters are 22% more likely to become pregnant themselves before age 20. Again, we talked about the teen. Educationally, they're less likely to finish high school. They're less likely they have a lower earning potential. We talked about their mental health in the slide before. Isolation is something that we don't often think about, because often these young women will say, well, yes, I have lots of friends. But what I heard over and over again in my dissertation research with these young women was that you find out who your real friends are. And people tend to flee when they find out you're pregnant. When they say, oh, I'll be there for you, what they mean is they'll be there to hold the baby when it's convenient for them. But it's not the kind of support that they need. And they feel very isolated because they can no longer pick up and just go and have fun and do the things that all of their friends and their people their age are doing. And we know that because of all of the risks we saw to their physical, to the pregnancy, that their health is also endangered. All right, strategies. Let's talk about strategies for prevention. Title 10 clinics. Every county has one, has access to them. These are those clinics where a young woman can go and get contraception. She can have family planning. I pulled this picture off the internet because I think it is very often still kind of that. The way people think about family planning and contraception is, okay, family planning advice, use the rear entrance. We don't want anybody to know that you're there for contraception. And unfortunately, I think that's still kind of a cultural norm, particularly for our teenagers, because, they're embarrassed about everything, right? They're embarrassed because their hair doesn't look right. They're embarrassed because their clothes don't look right. They're really embarrassed to have to seek out contraceptive care. So talk about availability. So while these clinics are available, they're out there, our teenagers can't always get there. And I have a relationship with a teenage girl who told me the other day, she's like, I made my appointment for family planning, again, because she had to cancel it several times because her mom drives her. She doesn't drive. Her mom drives her. Her mom's only off on a certain day of the week. And they had family issues come up repeatedly, and it was time for her contraceptive visit. But she had to cancel. And then I kept checking in with her. Hey, did you get your appointment? She's like, yes, but they called me because they ran out of depot. And so I had to cancel again and reschedule for a different clinic. So when we think about these clinics being there, it doesn't always mean that these moms, these teenagers have access, because, obviously she can't drive herself. She is at the mercy of someone taking her to this clinic. And she's also, at the mercy of what's going on in the clinic, because, it happens. They were out of the particular type of contraceptive that she needed that day, and the clinic canceled. And so it never ceases to amaze me, the barriers that our young women have to overcome to get to the contraceptive care that they need. And then health literacy. We can't assume that young women really understand how contraception works, and when it's appropriate, and when it's not necessary. I have a colleague who did a study and looked at just an adolescent's understanding of contraception and how, in pregnancy, and the questions that these young girls asked or the things that they said in these focus groups were really eye-opening. We had a couple who really believed that you can't get pregnant if you have sex in a swimming pool. And so, we can't take for granted that they really do know, but a lot of them do. But we need to make sure that they have access. And then where are they getting their education? Anybody want to take a guess at where our teenagers are getting most of their education about family planning and sex these days? You want to say it?
Oh, friends, TikTok, social media, their peers.
Yes, ma'am. Yes, ma'am. TikTok, peers, friends, absolutely. So it's not necessarily that they're getting great evidence-based knowledge about pregnancy and the risks of having sex and contraception. So we need to make sure that those evidence-based resources are out there and available where the teenagers are looking. But also, again, we talked about school clinics, healthcare clinics within schools, education being within those schools as well. And then, I think it's really important to be talking about, when you talk about prevention, talk about goals with these young people, moms and dads, or maybe not moms and dads, young women and young men, but what are their goals? One of the families that I help to take care of within our work here at Nurse Family Partnership, the dad is always at the visits, and he's super involved. He's such a wonderful father. He's got amazing goals, and I get the opportunity to not only kind of pour into her and her life, but also his. And it's really important to support these young people in what their goals are before they get pregnant and after. Because I want to make sure that nobody walks away from this thinking that adolescent pregnancy is like the end of the road for anybody, because it's not. For a lot of these young girls, it really focuses them, because they now know that they've got someone to depend on them, and they don't want to let this baby down. They want to be there for this baby. All right. So final strategies. Again, family support. It's vital that we are not just waiting until these young women get pregnant, but are we supporting families who have teenagers, who have young children, to meet their goals, to help them to be economically self-sufficient, to have stable relationships in their families, community support. We work in a lot of counties across the state, and we work in urban counties where there are a lot of resources, and we work in rural counties where there aren't as many. And I will tell you, it is much harder to support a family and help them to be healthy and achieve their hopes and dreams when there aren't a lot of community resources around these. So I want to, none of us can do this alone. We really have to band together with, local organizations, churches, places for transportation and housing and all of those things. That community support, we really need those wraparound services. Supportive programs for mental health, for childcare, and for continued education. Just a last plug for childcare is that a lot of these moms end up staying at home and being childcare for the other people in their family. And they also say, well, I'm not going to put my baby in childcare until they can talk. And that's a valid concern. And so, one of the things that we need to do is make sure that there's high quality childcare available for families all over our state, not just in those really high resource communities. These mamas want to be able to see their babies while they're at childcare. They want to be able to make sure that they're safe. And so those are just some of the things that we can do. And I know over the course of the day, the rest of the speakers will really dive into lots of other things that we can do to support these families. And so with that, here are my references. And let's see. There we go. So questions for me.
Yes, thank you again for that great presentation. There were lots of questions throughout, so I'm going to go back to that. We have a couple minutes. So the first one I see is there going to be a new ACEs study? They were told it wasn't valid due to limited demographics and because they were all insured and mostly Caucasian.
Right. That's not my research, so I haven't heard that. I think that would be wonderful, because I think it definitely, it was a large study, thousands and thousands, but it was done in California and it was done, out of a healthcare system there. And so yeah, I think that it really needs to be done in a lot of different places for sure.
Okay.
Great question.
Before I go to the next one, I just want you to know we're getting lots of hearts and hand claps for you. So they loved your presentation just as much as I did. Someone is asking, is the hospital giving birth control after they deliver? I think is the question.
So I can speak for UAB, and I do know that in some cases where a mom wants to have birth control before she leaves the hospital, that there was funding for things like IUDs and Depo-Provera before they leave the hospital, but that's not the case at all hospitals. But I do know that it's possible at UAB.
Okay. Someone said it's very informative. And there's a question. It said abstinence-only education seems to be most common in our area. Where and what should be included in the education piece?
That's
Yes.
that's a political question. So I'll just put that out there, and just say that having a conversation with educators, with administrators in education. It's one of those things, but it's really hard to know what is okay in our state as far as education within the schools. But I think there's a place for understanding. How do you get pregnant, so that we're not thinking that you can't get pregnant in the swimming pool. But also contraception. I think, when you see that trend line nationally and in our state, the availability of family planning and contraception is a huge piece of that. It's why that continues to go down. But education needs to be a part of that too, because one of the things that we do with home visitation, when we have a mom come into our program, we start talking about family planning and what her intentions are, really from the first couple of visits. And we're with them for 2.5 years, but that education around what family planning is appropriate for her and what's going to work best for her in her life is really important. And so I think that's a conversation that we need to continue to have and potentially have in schools. But
Yes,
that's
and there are options available because we have the Adolescent Pregnancy Prevention branch here, led by Ms. Valerie Lockett. And I know that her program is two parts. There's the abstinence, and then there's the, safe sex piece. And people decide, schools, programs, because she goes to different places, her staff, the grantees go to different locations. So it's what they want, what their audience wants. And of course, we do have our family planning program, which is statewide and lots of great information. And I know colleges are doing things. I mean, there's just so many people that are doing great things. So they're not neglecting either preference or just focusing on one thing. So,
yeah.
Okay. How can we advocate for all daycares and possibly schools to have cameras for transparency and protection of children?
Yes, please. I don't, I think that's huge. I think that is pivotal in getting our moms to stay in school, and to go to work, and do the things that they need to do or want to do in their lives to support their families is having that safe, feeling safe about their childcare. And that was something that really was new to me when I started talking to moms about, I assumed, you make a lot of assumptions in your life. And I often assumed that you're going to go back to school and put your baby in childcare. Well, when you don't feel safe with that childcare, that really is a huge barrier. I wouldn't put my child in childcare in a lot of places where these young girls live, because it doesn't seem safe to me. And I'm not going to fault anybody else for keeping their baby, staying at home and keeping their baby safe. And so I think that is I think we need to do that. I think that needs to be the next step in childcare.
Thank you for that. And also don't forget everyone to check out the Alabama Campaign for Adolescent Health. They are also a vital part of this work in our state, I am being told. So please don't forget about them. And let's see if we can get one more. I would just like to say one person has said that we have a lot of education and knowledge and support, and I know there are some people who study the child's brain and all that, and they may have something to say about this, but some people just we also have to instill in them, I'll say it this way, personal responsibility, because sometimes, that's all I will say about that. They say the education is out there, but we also have to teach them to be responsible. And sometimes young people are not, and we know why, again, their brains, but development and all of that. One other thing I want to mention is two more things. Okay. I think this question was in relation to being Black and other, because they're asking about UAB not mentioning Latinas and using the word other. And I'll let you speak to that because I know it's something about numbers and things like that. So
yeah. So I use those categories because those were the categories and the way the data was broken out in our state. And so it is difficult, because you're Hispanic or not Hispanic, and then those things don't necessarily cross over with whether or not you are Black or American Indian or whatever the racial breakdown is. And so those numbers are also fairly small for those other. And so that's the reason sometimes they get lumped in. It's definitely not a UAB thing. It's just the way the data is broken out nationally and at the state level as well. So I apologize if that wasn't clear enough in my presentation.
So just the last two things, seeing the numbers and charts really put things into perspective, and shows us what NFP nurses can focus more on. And then someone else also noted that there were so many similarities between what you were saying about the teens. I think, I don't know if it was their environment but what happens to people who are substance involved as far as shame, fear, stigma, trauma, mental health,
Yes.
and all those barriers. So again, thank you so much for your presentation today. We enjoyed having you, and they're still clapping and sending you hearts.
Thank you for the privilege. I appreciate
Thank
it.
you. Welcome back, everyone. We are about to move on to our next speaker. Dr. Holly Horan is an assistant professor in the Department of Obstetrics and Gynecology, Global and Rural Women's Health Program at the University of Alabama at Birmingham's School of Medicine. She is also a birth and postpartum doula and a perinatal health advocate. Her research focuses on maternal stress and birth outcomes, perinatal substance use, and collaborative perinatal care. Please welcome Dr. Holly Horan.
Good morning, everyone, and thank you, Samille, for that introduction. It's a pleasure to be here, and I just wanted to thank the Alabama Department of Public Health and the Gift of Life and Birmingham Early Head Start for this opportunity to speak today. So I was looking through the list of attendees earlier, and I feel like I'm in good company, so I'm excited to be here. And hi to some of my close colleagues and collaborators who are in the audience today. You know who you are. Let me share my screen really quick. Okay, let's get this presented. Right, can you all see my main screen, or do you see presenter view, Samille?
Yes, we can
Main
see your
screen?
main screen. Yes.
Okay, perfect. Okay, so today I am going to expand on a lot of the wonderful things that Dr. Knight, Candace Knight, brought up earlier in her presentation with her emphasis on adolescent pregnancy. But the emphasis of today for me is thinking a lot more about the interpersonal elements of care and support that we provide for pregnant people as a pathway for encouraging and promoting early relational health between new parents and the children that they have. And it's a call to really thinking about what is our responsibility as providers and professionals to make that possible. And so this slide is a little bit busy, but I just felt appropriate to give my gratitude and thanks first. And so all of these different organizations and funders that are on this slide are individuals and entities that I've collaborated with both in the past and still currently that have given me the foundation to be able to speak on this topic today. And I've integrated a lot of frameworks and information about research as well as research from Alabama to support this work. Okay. So for my disclosures, I have no conflicts of interest to disclose, but I am here in the interest of pregnant people and their families and supporting them to the best of our state's ability. And just a little overview for today. If you're like me, you like to know what the plan is and where we're going. And so I'm going to introduce myself a little bit more for those who don't know me here today and provide some learning objectives and outcomes and things that I would like you all to attain as folks who are here with me. We'll talk a little bit about stress and early relational health in general, both as concepts and frameworks for thinking about pregnancy and pregnancy support and maternal and infant health outcomes. We'll talk more specifically about maternal and perinatal stress from the biological level to thinking about topics that Dr. Knight was just talking about in terms of social determinants, sociodemographic factors, and other ways that they play a role in experiences of stress. And I'll talk a little bit more about trauma-informed care, which is an area of work that I've gotten into, given some of the collaborations that I have with Vital at the University of Alabama and studying perinatal substance use. And then we'll talk a little bit more about supporting and expecting in new families, how we can think about building a relational health workforce with the existing foundation that we have here in Alabama, as well as thinking more specifically about doula support, maternal stress, and early relational health as one of many different components to supporting families. And then we'll do a recap and a thank you. So that's the lay of the land for the next hour for y'all. So this is me. This is probably the best picture I have of my family within the last year. And we happened to be hiking on some of the coldest days in Alabama that were right around the holidays of 2022. We were in Lurleen Wallace State Park, I believe. So I'm a mother. I have a 7-year-old daughter, and a lot of my work, like Dr. Knight's work, is inspired by my own mother's lived experience as a Puerto Rican woman living in the Midwest and not having a lot of social support. So I am here on behalf of her and her legacy to make the world a better place. I am a medical anthropologist as well as a doula. And a medical anthropologist, folks may not be familiar with what medical anthropology is, but we are allies in the clinical and public health world. We are very interested in understanding the lived experience of clinical conditions, as well as what that means when we're trying to create initiatives and programming to improve outcomes. So we're really interested in investing and understanding people's experiences. I'm also an emerging community engaged scholar. I've been doing a lot of training over the last 4 years. It's always been a priority in my work to listen to the community and elicit their needs and perspectives. And I'm growing and learning in this space, but I always say that it's most comfortable for me to do this work when I'm listening to the people that I'm working with and for. And I know Samille and Ms. Jackson outlined some of my research areas earlier, but I study perinatal stress, and so I've looked at this on the hormonal or biological level, as well as at a social and structural level, provider level, individual and community level. I'm working on studying collaborative perinatal healthcare, both in the US territories and in Alabama specifically. I do work around trauma-informed care, particularly for perinatal health professionals who are serving pregnant folks and their families. I study doula support, and I've been a doula for more than 10 years now. I was trained in 2012, and I'm still in active but very small practice these days. I study perinatal substance use disorder and also rural perinatal healthcare, both in Alabama and elsewhere. And so just a quick shout out to our Regional 2 Perinatal Advisory Council. So I know Trendle Samuel, our fearless leader, is here today. And I have some other colleagues who may be on as well, but I am the vice chair of our Region 2 Fetal and Infant Mortality Review Committee and of the Black Warrior Community Action Team, which focuses on improving maternal infant health with an emphasis on infant health and well-being and reducing infant mortality. So if it wasn't for them, I would not know near the things that I know today and wouldn't have the support I need to do this work. So thank you. Okay, so I'm a professor, and so we're going to have some learning objectives and outcomes just to get everybody grounded today. So objectives are what I hope you take away from this session, at least preliminarily. And then outcomes, of course, are what I hope it inspires you to do when you leave this conference today. And so some of the objectives for today are to understand the science behind maternal stress and stressors a little bit more. We don't have a lot of time together, but I hope you glean a little something from this, or it reinforces what you already know. I want you to be able to describe the relationship between maternal stress and stressors and early relational health for new and growing families. And also to be able to explain how trauma-informed care and doula support can reduce stress and support early relational health. So very much complementary to some of the programs that Dr. Knight mentioned earlier. And then in terms of outcomes, the things that I hope this inspires you or encourages you to continue doing is to use an empathetic and compassionate approach when working with pregnant people. And just to be clear here, there is a difference between empathy and compassion, right? Empathy is being able to relate and understand how someone feels, and compassion is action. So compassion is doing something with that empathy to try to support that person that you're working with. So just being clear about that. The second outcome is valuing the ways in which stress and stress reduction can support health and healing for our pregnant folks, and how important even just the smallest acts of empathy and kindness can be for encouraging relational health, both within your practice as a professional, but also with the clients and patients that you serve. And then also, hopefully for some of you, this will be motivating to prioritize creating opportunities to cultivate and refine these professional and interpersonal skills if you don't already have them and are a master at them. Okay, so just to ground us a little bit in the why, so early relational health as a framework is not something that is new. It is something that has been around for a long time, but it has sort of ebbed and flowed in terms of its priority in the provision of healthcare, particularly perinatal care, but also other forms of healthcare, because we have a lot of different entities involved in terms of payers, in terms of technology, in terms of the shifting demographics and health profiles of the folks that we're serving. But what's really important in all of this, especially within the perinatal healthcare space, is that we need to have, there's a continued emphasis on the maternal or the parent-infant dyad or the parent and fetus dyad, right? So that is the most important part of all of this, that when we're thinking about this concept of infant health, that maternal health is right alongside it. And this is a framework from a recent article that came out looking at relational health and the components that surround it, both from a practice perspective as well as an interpersonal perspective, demonstrating that it is possible that relational health could be a significant part of improving infant health outcomes or perinatal health outcomes. And we'll talk more about that, but this is just grounding us in our why, what is most important here, and that's outlined in this golden circle. Okay, so I used some animation on my slide, so hopefully I can keep up with it. So why does stress and early relational health matter, especially when we're thinking about that pregnant person and that fetus or that parent and that infant? So I think it's important for us to think about what do we mean by stress and what do we mean by early relational health. I'm somebody who is a huge advocate for making sure that you're really clear about what you mean when you use terms to characterize the lived experience of a population. And so when we think about definitions of stress, we can think about acute versus chronic stress, the stressors we have once in a while versus those we experience over the course of a lifetime or a longer period of time. But there's also broadly two different types of stress, right? So we have eustress, which is typically good stress. It's stress that motivates us to get that presentation done. It's stress that motivates us to make some quick and important decisions that are meaningful for someone's well-being. It's good stress, and it's even stress that can be a product of being surprised in a very happy way, right? So it's anticipation, it's things that are positive in nature. And then we have distress, or that's thinking about things like bad and toxic stress, whether that be acute or chronic. You have a negative experience with somebody that you're talking to, you are subject to social and structural determinants of health and violence, and different things like that. But when we're thinking about stress broadly in this context, we're focusing on this notion of distress, right? And of course, eustress plays a role in terms of thinking about resilience. But what we're going to be talking through today is thinking about how to reduce distress and promote eustress in these interactions. So when we think about the concept of stress broadly, we have sort of three primary elements here. We have external elements, so environmental components, social determinants, things of that nature. We have internal or biochemical elements that are involved in our stress experiences. So we're looking at hormones, as well as our physiologic or physical reaction to stress. And what's interesting for a lot of us who study stress and health outcomes is thinking about the external and the internal and how they interface with one another. How can we truly understand the relationship between what's going on externally and how it impacts internally, and what does that mean for health outcomes? So in terms of operationalizing relational health, broadly, it is the capacity to develop safe, stable, and nurturing relationships. And for those of you who are in this field and familiar with this concept of relational health, you may be familiar with the abbreviation SSNRS. And the idea is that relational health, safe, stable, and nurturing relationships can buffer against distress and build resilience. And this is important to think about because I think when we're talking about infant health and well-being, we often think about it as the family unit or that immediate circle right out of the family unit in terms of the community. And those are really important elements. But there's also a responsibility that we have as people who care and support pregnant people to facilitate and model this as well. So when we think about relational health, it is often strengths-based. So we have Strengthening Families program that I know is offered in this state, which is a wonderful program. So I know that's something that's available to our families. And there's an emphasis on relationships and respect, right? It's also solutions oriented. So we're creating these safe and stable and nurturing relationships. And then we're thinking about how we can use these as a platform to address challenges that people are experiencing. And then the individuals that are involved in terms of relational health is widespread. It can be the individual, family level, community, but today our emphasis is on the healthcare system and allied professionals within that space. So I wanted to share a little bit of qualitative data from the research that I've done, particularly a recent maternal and infant health research needs assessment that was statewide. It was done in all 5 perinatal regions of the state. And we did interviews with providers and professionals and focus groups with birth parents to ask them, what are the biggest problems and what do you think should be done about it in terms of research? And so they shared some really interesting insight in terms of thinking through some of the challenges of doing this work. So why does stress and early relational health matter? So the first quote is from a provider, and they said, you can't have a healthy baby if you don't have a healthy mama. You can't have one without the other. I think some care providers, legislators, and politicians forget that. So they're expressing their frustration with the lack of an emphasis on maternal health and well-being in our efforts to improve familial health as well as infant health. And then another participant who was a birth parent shared, it's like the mom is the candy wrapper and the baby's the candy. And so the mom gets put aside and the baby gets all the attention. So all of these people are well-intentioned and have full investment in improving care for people who become pregnant and their infants. But these are sites of frustration for them and how people are feeling outside, and they're reflecting on that outside of the clinical space. Okay, so why does it matter in terms of thinking about maternal health in particular? So we are facing a national mental health crisis that I think all of us are to some degree familiar with, and this has potential for serious health and social consequences for years to come. And this is something that has been put out by multiple federal agencies in terms of the concern around the national mental health crisis, especially after and during this COVID-19 pandemic. And so this also applies to maternal mental health. And so we know that undiagnosed and untreated maternal mental health conditions are associated with an increased likelihood of maternal morbidity diagnoses, poor perinatal and infant health outcomes, but there's also an effect on the birthing person, the infant, and their family, not only from an outcomes perspective, but also from a developmental and cognitive perspective as well. So there are implications for not being in tune to the mental health needs of our mothers, even if they present with no physical concerns. We know that suicide and substance use are some of the leading causes of maternal mortality, both in our country as well as in various regions and in our state. And what's most important here is that we know perinatal mental health conditions are the most common complications of pregnancy and childbirth, and that they affect approximately 1 in 5 women or people who can become pregnant. And what's challenging about this is that 75%, almost 3/4 of them go untreated, and 100% of them respond to early interventions and or treatment. So we heard about some of the wonderful programming that's happening with home visiting and supporting adolescent pregnancy. But what do we do when there's a lack of access to resources? What do we do when it's hard to get that referral? We know there's limitations around the accessibility and availability of mental health support and providers. So what can be done in small ways to address this concern or to begin to address it? And that's the question we're going to talk about a little bit more in this presentation. And so this is another quote from one of the participants who was in that study, talking about birth trauma and the way that it's women and people who become pregnant hold on to that and how that has implications for mental health. So hearing from stories of women who have had a traumatic births, and there's 3 years, 4, 5, 6 years, 10 years later, and they're still dealing with, it's like, you need to go see someone, and why has nobody told you this, and why has nobody stepped in and said, it doesn't matter how long it's been since you've had your child, if you're still caught up on this, you need to get mental health counseling about it. So there's a big concern in our state related to the mental health and well-being of our pregnant and postpartum parents and the relationship that it can have to both bonding and attachment as well as infant health. So I want to take a little bit of a deeper dive into thinking about maternal and perinatal stress. So how do we understand both the physical effects and the factors around maternal and perinatal stress? And hopefully this is in addition to what Dr. Knight has shared or complementary to that. So I'm going to be really mindful not to be redundant here for those who were able to attend the first presentation. So like I said, when we're thinking about stress in this context, we're often thinking about distress rather than eustress. And when we think about distress, there's some things that we need to take into consideration when we're evaluating someone for their stress experiences. We're thinking about the intensity of those stress experiences, how long they're lasting, whether or not those stress experiences have any type of pattern or predictability, as well as their individual life history. And I know in the first presentation, she talked a little bit about life course considerations, and that also plays a role in terms of thinking about the individual's life history and how this distressing or stressing factor is appraised. So like I said earlier, it can be acute or chronic, but it can also have psychological and physiological consequences, or both. And then we know that there are factors that can exacerbate or make it worse or agitate stress experiences. And the literature and a lot of research supports that low social support is one of the #1 factors associated with distress that can become magnified and becomes something that is physiologically expressed and translated into health outcomes. We know that we see more offspring health or behavioral health problems for people who experience particularly chronic stress, or stress that occurs in patterns. And then we see more family conflict, as well as enduring socio-environmental stressors. So there are things in the environment that are creating these situations that are being appraised by that individual as stressful or chronically stressful. And so these are all things that play a role in pregnant people's lives as well as other people's lives in terms of perinatal stress and the experiences of stress and how they are experienced by the individual. So I saw a comment in the last presentation about adverse childhood experiences, and I did want to say that for those, some of you might be aware, but there is the Pittsburgh Adverse Childhood Experiences study that was done. I think the first paper was published in 2015, looking at other factors associated with adverse childhood experiences and how those were appraised by different racial and ethnic and cultural groups. And one of the main findings from their work is that all communities have some form of ACEs. It's just the scale and scope of those ACEs can look a little bit different. So when they were working with other populations in their study, they noticed that a lot more community level stressors were seen as being more relevant than some of the individual level ones, particularly around safe neighborhoods and support. So ACEs is something that I think they're working on to improve. And so that Pittsburgh study can be really instrumental in understanding some of those changes in the last 8 years or so, or the changes that they anticipate making. But what we do know is that adverse childhood experiences across communities are associated with mental health challenges, physical health challenges, and when it comes to infant health and well-being, there's infant feeding issues, as well as a higher rate of insecure attachment and poor infant socio-emotional functioning. So we do see those connections, and I think time will tell to see how the expanded ACEs will be able to show us more about how those uniquely affect different communities. So this has a lot of words on it, this slide, but I really just wanted to capture a couple of elements on it here before we move forward. When we think about mental health and well-being, and particularly stress in our perinatal health population, one of the approaches that has been advocated for but can be hard to implement is what's called a biopsychosocial approach. So if you see these big circles here, I hope you can see my cursor. So we've got this biological circle, which is our pink one. We have the blue circle, which is psychological. And then we've got this yellow circle, which is social and environmental. And we see at the center or the intersection of these, there's mental health, but then also below it in the green, there's family relationships and life events. And so this is an approach that has been promoted and integrated into both social science and clinical health research to say we need to look at people a little bit more holistically. We need to treat them a little bit more holistically because the intersection of biology, psychology, and social and environmental factors plays a really big role in their well-being and how that not only plays out within our encounter with them, but also what that means for their family relationships that they have and the relationships that they have moving forward. So like I said, this is a small step moving in that direction, but I think it's really important for us to recognize the power of those connections. So this is called the biopsychosocial model. Oops, that figure was supposed to come later, but that's okay. It's making its grand appearance right now. So as I stated a little bit earlier in the presentation, I've done a lot of work on the biological level of understanding maternal stress, particularly working with the hormone cortisol, which is a key glucocorticoid or hormone that's part of that stress system when our body responds to a stressor and then it returns to a pre-stressor state. And so in this figure on the left, we don't need to get into the weeds too much here, but there are existing theories and bodies of research supporting the relationship between maternal stress experiences and repeated high levels of cortisol in the body and the impact that that has on stress function during pregnancy, and also the impact that that can have on the placenta's ability to convert active cortisol into inactive cortisone, which is what the placenta is supposed to do to protect the fetus from those higher levels of cortisol that may be going through the maternal body when they're experiencing a stressor or a chronic stressor. And so, like I said, we won't get too far into the weeds here, but there is a placental enzyme, as you can see here. I think there's my cursor right there. I hope you can see that. And it's got a big long name. It's 11-beta hydroxysteroid dehydrogenase 2. And that is the placental enzyme that is responsible for converting maternal cortisol into inactive cortisone. And if that placental enzyme is not functioning optimally, or if the amount of cortisol experienced in the mother's body is overwhelming that system, we have seen implications for fetal growth and development as a result of higher levels of cortisol and higher stress. Now, I will say that research is still under development and very much underway, but there is a growing body of research supporting that, as well as a body of research supporting for women, particularly for pregnant folks who are chronically stressed over their lifetime, showing what they call dysfunction or a difference in their cortisol secretion patterns that may have other implications for pregnancy and maternal morbidities. So one thing I'll say before moving on from this figure is that we know levels of cortisol in particular, which are part of our stress system, rise steadily in the first and second trimesters. They peak in the third trimester right before birth, and then they go down postpartum. But we see that different types of profiles for cortisol may be associated with different outcomes in development. So that's this figure on the left, and then up at the top in the right-hand corner, this is just a simple figure showing some of the recent work that's come out looking at what we call the intergenerational transmission of experiences during pregnancy and birth that can impact subsequent generations. And so how that plays out is we're looking at what they call FO, which is the mother. And so if that mother has a lot of stress in her life, that's going to not only impact that fetus, but also potentially the development of the germ cells, which become that fetus's eggs and or sperm that they create later in life, right? So mostly eggs when we're focusing on female populations, but that there could be implications for multiple generations, especially if there's a lot of stress or stressors that they're experiencing, not only relational stress, but also nutritional stress, other types of natural disasters or things that may happen, as well as illness and injury. And so one of the things that I also like to highlight is that when we think about relational health and supporting families, we may not only be impacting them, but we may also be impacting future generations from both a relational perspective as well as from a physiologic perspective. And then this final fun figure down here in the right-hand corner is looking at those experiences of life experiences, how they're related to looking at the biological, the psychological, and then the biophysical and behavioral components, how that may impact gestation and the biology of gestation in the ways that I recently talked about, and the implications that that can have for the fetus. And so one more word that I believe most people are familiar with in this room is thinking about sort of the epigenetic implications, or what can happen to the genome as a result of environmental experiences to change expression of the genome to present certain outcomes that could be considered less than optimal. So those are, I don't want to get too far in the weeds, like I said, but these are some ways that they've been thinking about it in terms of basic science and how to understand the relationship between lived experiences and what happens at a physiological level. So when we're thinking about this, it's also important to think about what are those environmental components as well. And so this figure is from the Centers for Medicaid and Medicare Services 2019 report on rural health and rural perinatal health. And this is a social determinants of maternal health framework. And this actually emerged from the World Health Organization and was adapted for this guide that came out. Oh yes, my sources are in the bottom left-hand corner. And so what I wanted to point out with this figure is that we know that there are a number of social and structural determinants involved, but this figure in particular calls attention to the maternal health system and the ways in which we can start to address some of those issues at this level. You know, certainly we cannot go back in people's lives and change their lived experience, but what is the responsibility of our maternal health system to support pregnant folks to have a wonderful experience, to have a positive experience, and what does that mean for their families and their health over the life course? And so that's why this box here in red is highlighted. So there's a number of factors there. And so the things that we're focusing on in this presentation are thinking about patient-centered and high-quality care. And then in addition to that, we also have structural determinants of health that are really valuable to think about. And this is from the Career Peri article that was cited in 2021. So as stated at the beginning of this summit, as well as in the last presentation, there are a number of socio-historical elements that need to be factored in as well, particularly when we're trying to understand folks' lived experience, why they may be responding or reacting the way that they are in the clinical setting, as well as how that plays a role in their perceptions of health and health outcomes, right? These are all really important things. And so this is a really important piece focusing particularly on the deep racial history that we have in our country and the way that this plays a role in increased maternal and infant mortality in the US in particular. And so there are a number of things in these models that are really important for us to keep and to hold and to keep in mind as we're working with people, recognizing that we may only be able to interface with them in the maternal health system, and that providing relational care is of the utmost importance to be able to allow these people to feel safe and to get the care and support that they need to care for their families. And so a couple of quotes from the people who have given birth in our state and what they needed, how they were experiencing stress and how they needed support. And so this person said, I had a scheduled cesarean at 38 weeks and I was not traumatized by that. I was prepared, but afterward I didn't know how to ask for things. And so I was just laying there after my cesarean, barely having any participation in my birth process. I was very disconnected from my child. I honestly didn't even think that was my baby that came out of me. Now knowing better, I could have asked for the baby to stay with me. I could have asked for things like skin to skin and more support, but that shouldn't be something that you have to ask for. It should be the standard. That's very important. I honestly did not feel connected to my child whatsoever. It took years for me to feel connected to her. And so I think this is important because it's speaking to the power of how very acute situations can have significant impacts for maternal and infant well-being and bonding, right? And just the power that we have in the maternal health system to be able to support that or to serve as a barrier for that. So here's another example from a birth parent. And she said, my first checkup was at 6 weeks and I suspected that I had postpartum depression. And I said, hey, I'm having these feelings of sadness and crying spells and not eating, blah, 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 whatever the symptoms were, and explained to him and was literally crying in his office. He tapped me on my shoulder with a smile because he's very smiley. And he said, well, you know how y'all are, strong Black women, and laughed. He was like, you'll be okay. And that was it. He didn't offer antidepressants, nothing. And so I think what's important here is that when we think about relational health, when we think about providing patient-centered care, when we think about what it means to be relational and provide therapeutic encounters, is that it's more than smiling. It's more than just saying a couple of things. It's about relationship building, right? Emphasis on relational and listening to people when they have those needs. So this is a really good example of that though there was no harm done from the provider's perspective because they were still smiling and responding, but there was a missed opportunity to care for somebody who was struggling with mental health. And this had implications for her ability to bond and care for her child as well in the weeks following this encounter. So one of the best ways that I've been able to think about what can we do on a small scale? What can we do without additional technology? What can we do without extensive additional training? And what is something that we can continue to work on in a feasible way to support people who are pregnant and the relationships that they build with their family to support optimal health and development? And so trauma-informed care is one approach to thinking about this, particularly within the clinical space, and particularly when serving not only pregnant people, but pregnant people who are experiencing adversities. And so I know some of you are very familiar with this. There may be some folks in here who I've had the pleasure of working with in a trauma-informed care training for perinatal support professionals. But the idea is that you are committing to providing a culture of safety and empowerment and healing for that patient, because we know that almost everyone who's showing up with us has had lived experiences, as pointed out in those social determinants and or structural determinants of health that shape who they are and how they feel in the clinical space. And so there's 6 components. I won't go in depth into all of them because I don't think we have time for that today. But if you want to know more about them, feel free to email me after this. I'd be happy to chat more. So the first is safety. So ensuring physical and emotional safety of everyone involved. And so we tend to think about this concept of safety in a few different ways. There's sort of the clinical definition of safety and liability, but there's also the socio-emotional components of safety when it comes to that therapeutic encounter or that professional and supportive encounter. So those both need to play a role, right, in terms of creating that safe space. I've been to a number of prenatal visits over the course of my work as a doula, and I will say every time when a provider sits down and makes eye contact with their patient, it's very, very meaningful for them. And I've seen a lot of that. I've also seen a lot of providers make very little eye contact and standing up because they may be in a hurry, right? So even these small, tiny things are really, really important. Peer support, so including people with shared experiences to help promote healing, so making sure that folks are connected as much as they can be to different support groups or different outlets for being able to connect with people is really helpful. Also thinking about who is part of their care team can be a big part of thinking about that peer support, and we'll talk more about that in just a moment. There's collaboration, which is sharing the responsibility and the power while making decisions. A couple quotes back when that mom was sharing her experience about having her cesarean birth, it was something that was planned. She had a condition that necessitated it. So of course we celebrate that she had access to cesarean to be able to have a safe birth, but she didn't feel a part of that process at all, particularly what happened after the baby came into the world, right? So a really big part of thinking about how to provide the best care and to make sure that people feel involved and what that means for their health and well-being moving forward. Then there's empowerment, voice, and choice. So making sure that all of the decisions, as many decisions as possible when it comes to care, are informed, and that we're assessing decisional capacity. And I'll talk a little bit more about trauma responses in a minute, but what we appraise as someone understanding or not understanding can be easily confused with the response or a trigger that they may be having in the clinical setting or in the professional setting, right? Because no matter how we slice it, there is a power dynamic at play. There's a power dynamic at play, and we need to be sensitive to that when it comes to providing any type of education, psychoeducation, and what that means for the patients and clients we serve. So the 5th one is trustworthiness and transparency. We want providers and professionals to be honest, but to be as positive as possible, right? If there's a potential for a bad outcome, if there may be a risk that is on the horizon that we're starting to see as someone progresses through their pregnancy, just being really clear that that's something that they could be experiencing, but what kind of hope can we instill in people that's realistic and allows them to feel optimistic about their experience? And then, of course, there's cultural, gender, and historical issues, among many other factors. And so this is where we're getting into our biases and our stereotypes and the role that historical trauma plays in the everyday interactions that we have with the people that we serve and how they appraise us as the people who serve them. So when we think about a trauma-informed approach, there's these goals. They're called the 4 R's. And some of you may be familiar with them, especially if you've been in a training with me. And I think we're really at the point where we can talk in this presentation about the first two, but the last two are going to be on the folks who are here who are saying, hey, maybe this is something that I want to integrate as a professional, or I want to integrate to sort of shift and support the culture of my practice and my group that I work with. And so the first R is realizing that everyone, or most people, experience trauma. More than 2/3 of adults report experiencing trauma over the course of their life. And it's suspected that that is an underestimate of traumatic experiences that people have had, but also understanding that trauma can manifest a number of different ways. And what does that mean for health and recovery? Also, to be able to recognize symptoms of trauma in clients, family, and staff, and others who are involved in caring for them is really important. But it's not something that you can simply do overnight, and it's not something that you're simply going to be able to take away from this training. So actively working, thinking about that, creating opportunities to do some respectful care modules, which are available through Acoff, or other things that can be done to facilitate recognizing these experiences. And then the last two, like I said, are outside of the scope of this presentation, but important for folks to keep in mind moving forward. So being able to respond, that's where we go from being empathetic to compassionate. Respond by knowing what they're experiencing, how that integrates with the protocols and procedures at your practice, what can be done, what needs to be referred out. These are all important things to consider. And the overarching goal is to resist re-traumatization, to see this support and professional spaces as places where families feel safe and valued. And so when we think about what trauma does to our body, this figure on the left, there are a number of different ways in which trauma can manifest. And I've seen a lot of these as a birth professional manifest in different ways, whether that be during a prenatal visit or during labor and birth, or in the postpartum setting, right? Depending on what's going on both within and outside of the clinical setting. And so one that I want to call attention to in particular, well, let me run through this list on the right and then we'll go back. We'll go back to this. So our brain recognizes a threat. Our stress response system is one of the most primitive systems in our brain, our oldest systems in our brain. It keeps us alive. And when our brain recognizes that threat, we have our autonomic nervous system reacts. Our heart rate goes up, we may start sweating, digestion ceases, other systems slow down to support being able sort of to fight or flight in most situations. So there's a cascade of hormones that lead to that response, as well as another cascade of hormones that allows us to return to a pre-stress state. But the question becomes, especially for people who are coming from marginalized groups, is what happens when we don't return to a pre-stress state? What happens when we can't find those safe spaces, when our brain can't appraise that we are feeling safe? Right, so those are questions that we have, and trauma-informed care, while it cannot solve all those problems, can allow a moment of safety for the people that we serve. And so in the image on the left, I think one of the most important ones is both the freeze and the fawning here, because we don't talk about those as much. And so one of the resources that I'm using to explore the field of compassion science, which we'll talk about in a moment, talks about how when you are talking to a patient or a client and they're non-responsive, or they say something, they just say, okay, they may seem disconnected, they may seem like they're not engaged. What that actually could potentially be is a freezing response, right? They don't know how to respond in that moment. They are feeling uncomfortable, they are feeling unsafe. And that it's not that they don't care, it's that they are having this type of response. And so I've actually just experienced this with a client recently, where her provider was providing some very important information with her about why she was having stress tests during her pregnancy, non-fetal stress tests during her pregnancy. And she was so nervous by the fact that she had to have them that she completely shut off everything else that was said to her. And so it was important for us to debrief and have that conversation and to have that second set of ears, because she was like, I was just too nervous. I couldn't focus on anything anyone was saying. But we also see the fawn response happen a lot, where you have a patient who may have a very specific way that they present. They may be very confident, or they may be, being able to advocate for themselves. But when things happen that are unanticipated, they may start to become more like, okay, whatever you say, whatever to keep the baby safe. And those are all important things. Safety is so important, but recognizing that they are feeling fear in that moment and that they need someone to comfort them and to explain to them what's going on and to make sure that they're getting the support they need can be very, very important. So just paying attention to small things that are happening in the clinical space are really important for understanding this approach. Okay. So professional support and compassion science. So it's pretty clear that trauma-informed care is not something that just comes from one provider. This is a practice, a system level emphasis on supporting people and making sure that they feel comfortable. And there's a whole body of literature from about half a century looking at compassion science in various forms. And so this book, Compassionomics, some of you may have read it. I just learned about it at a conference I went to recently this summer, actually walks us through 50 years of medical literature on how compassion can be healing. And so what's important about that is that sometimes it's hard to measure and understand compassion. And so how do we build that into what we do from a health systems perspective? And I love this quote from Maya Angelou. It says, "I learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel." And this is a really big part of compassion science and what they are advocating for in the clinical space. So when we're thinking about early relational health within the context of this presentation, we're talking about universal preventions. So I'm focusing on safe and effective communication as a pathway for supporting people and exercising compassion. And the implications that this has are significant, particularly from the body of literature that exists in compassion science. So we know one of the biggest priorities is ethnic and cultural congruence when possible in care. And we recognize, unfortunately, at this point, still we cannot always meet that need. And so if nothing else, you can have humility. Going back to the conversation about ACEs, right? We know that ACEs is based on a population of folks that's pretty exclusive. And there's work being done to expand that, but recognizing that there may be more than just what's on that assessment is really, really important. And what the history of compassion science has showed is that when providers show compassion, when people who are professionals show compassion to their patients, and support them, there's increased levels of patient empowerment, patient engagement, patient efficacy, and patient adherence. Part of me wishes I had another hour so I could talk all about compassion science, but these are real outcomes that are important for thinking about why compassion matters, even on some of our hardest days, right? Everybody's not going to have a perfect day when we're serving folks, but it's really, really important in terms of better outcomes for patients and clients. And what's central to both of those things is shared decision-making and transparency. So making sure that patients or clients are feeling like they're a part of the process, asking them questions instead of them just asking you questions, and making sure that it's more conversational if possible, as well as being transparent. What's going well, what's not, and what hope do we have to look forward to in the future? Okay. So one of the ways in which a provider showed compassion to one of the participants in the study that we did here in Alabama made a really big impact on her, and especially her mental health and recovery postpartum. So she said, "I had a traumatic birth. A few weeks later, I went to my OB to process it because I felt like I had a lot of questions that went unanswered. My OB said, 'We see this stuff all the time, and we just don't think about it because we see it all the time.' Then my OB sat down with me, brought my file in, and told me everything that happened. After that, everything made more sense." So if we juxtapose this experience that was just shared with the one about the woman who was seeking support postpartum for her suspected postpartum depression, those are two very different approaches. Both providers may have been very, very nice, at least at a superficial level, but one took that extra step. They did the compassion piece, which is where they took action to help support that person in their healing. So applications of trauma-informed care. There's sort of three components that I want to talk about here. Is communication, body language, and behavior. Just because you're not being mean doesn't mean that you're being nice and compassionate, right? So the absence of one does not mean that the other one is present. And so just being mindful of that is really important. So being able to paraphrase what folks are saying to you, patients or clients, and doing the teach back method. So if you're a clinician, you are probably familiar with the teach back method. So what I'm hearing you say is, and making sure that you're getting it right? And also checking in Q&A, like, how is this working for you? Are you having challenges here? These things are simple. They are simple, simple things. But what we do know is that when a clinician walks into the room, a skilled clinician walks into the room, somebody who's been in practice for a long time, they will often make a decision about what the patient is experiencing and what needs to be done next in less than 20 seconds. And we've seen that patients who are able to explain themselves typically only need somewhere in the range of 30 to 40 seconds to be able to fully articulate what they need. So if we're able to sort of balance out that time a little bit, it's still something that is conceivable to achieve within the short encounters, especially for our pregnant patients that they have, because we know that many of them who seek obstetric care only have 15 minutes prenatally, right? So a lot can still be done in that 15 minutes. Person first language is very important as well. So checking in with that individual, asking them to introduce themselves or to say their name correctly can go a very long way in terms of building respect and rapport. Another important part of that is saying hi and welcoming everyone in the room and introducing people in the room, right? If you're coming in with a nurse practitioner or other people or students and stuff like that, introduce themselves and then say hi to the people in the room. It takes not very long to do that. And it makes people feel welcomed and comforted and like they matter in that space. That can go a long way. And emotional intelligence is also something that's really important. And emotional intelligence is something that you have to work at. I just took another emotional intelligence training yesterday, so I feel very confident in saying that. So assessing, are the participants' needs met? Who can help you meet those participants' needs? Because one person cannot do it all. And do they feel involved in the process? Honestly appraising the situation or even simply asking them that can go a long way. Right? So these are all small things that can be done to make a really big difference in how a patient feels or a client feels. So trauma-informed care is something that can be implemented by anyone who's working with pregnant people, support professionals, clinicians, allied behavioral health specialists, you name it. But there's also a call to build more of a relational health workforce because we recognize that providers and their clinical staff are critical to this process, but they can't do it all, right? They cannot do it all. And so there's been a call for building more of a community perinatal health workforce. And this includes a number of different professions. Dr. Knight is from Nurse Family Partnership, so certainly nurse home visitors are a critical piece of that. And I've had the pleasure in the past of working alongside them as a doula. Not in Alabama, but elsewhere. It was a really wonderful partnership. But we have doulas who are, I'll talk a little bit more about what they are on the next slide, but they are non-clinical support specialists. We have nurse home visitors like Nurse Family Partnership, lactation and infant feeding specialists, which we have in this state, but there's still limited access, especially for our families who are receive Medicaid. So we need to think a little bit more about how to support them. Community health workers. So shout out to Connection Health. I think I saw Lynetta West on here earlier. And then also peer-to-peer support and group prenatal care, which is something that's happening at programs like our CAP program at UAB, right? And that serves our pregnant folks who have substance use, who are substance involved. Oh, and one thing I wanted to point out here is that the Center for the Study of Social Policy and Health Connect 1, which is a community doula program, it's not in Alabama, but they're working together to actually create modules for early relational health training for doulas, and they're testing that. So more to come around that in the future. Just want to make folks aware. So these two quotes amplify why that is important. So there are supports, but there's also a lot of knowledge that's just lost. And if you don't know to look for it, if you're not really dedicated to breastfeeding or safe sleep habits, for example, then all of these things kind of fall in the mom to figure it out thing. Then it's really hard because you're always just Googling and getting contradictory information. So this speaks to some of the challenges with our adolescents, as well as our new moms and people who are experiencing new challenges in perinatal and infant health for the first time. So sometimes it's just about making sure they know where to connect to the right place. And the other person said, I wish that OBs and pediatricians would diversify their knowledge when it comes to breastfeeding and postpartum. Even if they couldn't diversify their own knowledge base, they could help connect me to services by saying, well, I can refer you here, so I don't have to go on a scavenger hunt to figure out what I have to do next. It would be wonderful if they could do that instead of leaving you wanting and needing more. So clearly we know that our state has an abundance of resources to support families. And I think there is a lot that we can think about in terms of being able to make that information more accessible. And then one more quote before we get to the last slides here. We need more of all different types of providers. We also definitely need doula care for all women who want it. Even if the person in labor doesn't know they need a doula until right in that moment, they should always be able to pull the doula card. I feel like that would be an ideal change for birth parents and birth outcomes. So another support for building that relational workforce, starting with doulas, but also thinking about the other programs we have in the state. So just real quick, being sensitive to time here. So doulas are non-clinical providers who provide physical, informational, and emotional support to families during pregnancy, childbirth, and the postpartum period. We have a number of different models that exist in our state, mostly independent or private practice models or small practice models, as well as community-based models. We have the Alabama Prison Doula Project. We also have Birthwell Community Doula Program. So shout out to some of those community doula programs. And then hospital models we don't see as much of here, but there are some collaborations such as Dr. Robinson up in North Alabama, who has intentionally collaborated with doulas in her practice. And so the list of things that we see on the right are all the ways that doulas work with families to build that relational health. So the most important part of what we do is to build rapport. We provide personalized support and engagement. We inform and empower our clients to help them get their needs met and to ask the questions they need to ask. We encourage them to have body and medical literacy. So what's happening to you and what can your provider do for you? We help them with warm resources and connections, especially connecting to other home visiting programs like opportunities such as Nurse Family Partnership and other opportunities that may be important for them, especially to address their clinical and developmental needs. We help them with planning and preparing prenatally and postpartum. We listen, we hold space for them. There is physical support during labor. We can help with infant feeding and bonding. And we can also do emotional and physical check-ins and help with referrals as needed, particularly in that postpartum period. And in our state, I know we have some support for our peer support doulas. So those are people who are cross-trained as peer support specialists and doulas who provide an additional level of support for our families. And so those are just some quick outcomes data for the doulas. So they can reduce unnecessary cesarean births, shorten the duration of labor, reduce Pitocin use, reduce the requests for epidurals, and also help with mood and anxiety. But overall, they help improve the patient's satisfaction with the birth experience. And we really do that through our mother, or parent, the parent approach. So we focused on the practical and psychosocial needs of the family. We help provide resources and referrals for newborn growth and development. We support postpartum recovery, particularly parent and infant bonding. And then we also do some concrete instruction and role modeling for helping the family be involved if that service is needed and supported. So that's a slide showing that doulas make an impact, but I think I'm running a little low on time, so I'm just going to kind of slide through that. Happy to share that one later. And so this is my recap slide. I'm just saying that maternal stress is an important part of how we thinking about how to better support and care for people, and it could have effects intergenerationally. It's never too late to demonstrate compassion, and that can have a ripple effect. Trauma-informed care is a quick way to consider how to approach pregnant people and create a safe space for them, and that building a relational health workforce is very important, and that other support professionals such as doulas have been shown to make a difference. So just bringing us back to our why, our parent and our baby, and why this all matters. Thank you, everybody. Appreciate your time.
Thank you. We're getting lots of hearts and hand claps for you. They really enjoyed this session. Lots of great information. People love that quote that you gave. They were also giving thumbs up when you were speaking about just simply asking someone, how do I pronounce your name? Like, introduce yourself to me. They're still clapping and sending hearts. So I'm going to go to the questions that I do have. Just one comment from Mr. Green. He's speaking on the fact that trauma-informed care is incorporated as an integral part of the Birmingham Healthy Start Plus service methodology. They can see how important it is, and they're trying to find ways to evaluate the effectiveness from an evidence-based perspective. And do you have any suggestions for him?
That's a really, really great question. Because I think what's important here is that we're trying to measure something relational, and sometimes it's really hard to turn something relational into something objective and measurable.
Mhm.
And I mean, what I can say is that I would certainly encourage you to take a mixed methods approach. I'm sure you're already thinking about this, but having a way to sort of measure it through, patient satisfaction, or even the person who's providing that care. I know doulas work with his organization, and so measuring that, both the provider as well as that client perspectives and how they're feeling in terms of satisfaction, and then also being able to just chat with them even, or debrief about their responses to something quantitative like that, would be a really nice set of information that could provide both numbers and anecdotal or narrative information to support their work. I'm so happy to hear that.
Okay. Ms. White just wanted to confirm that she and the rest of the UAB perinatal nurse navigators were in attendance.
Yay! Thanks for coming. Hooray. Thank you.
There's a question. After the women deliver and they go home, if they have a health problem, is UAB available to see them easily?
So I'm not a clinician, but that is a great question that maybe one of our nurses can answer if they're on here. So if you're a nurse, please chat in there. I hope the answer to that is yes.
I'll look for that.
Excellent question. Thank you for asking that. It's important.
There's a question. What are you seeing about maternal stress, cortisol levels in preterm birth?
Yeah, so that was actually my dissertation research. And there's been a lot of work trying to understand what they call phenotyping. So they've tried to basically understand how various lived experiences play a role in the physical mechanisms that lead to preterm birth. And I would say that there's more supporting evidence that there's an association, but at the physical level, we aren't quite sure what that mechanism is, right? And so a lot more work needs to be done in terms of connecting those external and internal components to think about, is there a way that we can be able to evaluate, support, and predict what might happen? And the reason I say that is because my own mother was somebody who had 3 preterm births. Her water would break early with no sort of clinical indication besides her history. And that the hospital that she gave birth to my youngest brother in actually asked her to get pregnant again so they could study her.
Wow.
Because they couldn't figure it out. And so that work is still being done. She did not get pregnant again, for the record, but that is something that they're still working on, and it's a very important question. But the association is there, especially for people who have a history of preterm birth or who were born preterm themselves.
Okay, and the answer to that question about following up if you have an issue, yes, UAB's MEU can see anyone 20 weeks, 4 weeks postpartum, no appointment needed. There's a phone number, 205-975-6105. Thank you, Laura.
Oh,
Okay.
look at that collaboration right here.
Another Laura commented that she really likes the Centers for Disease Control Hear Her campaign. There's a lot of good information to share with clients, so please check that out.
Yes, please.
Yes, and you can also, Cherie is saying you can schedule a follow-up appointment with your provider, and they have that 24/7 thing for UAB. Yes, I will share this. I will share in the chat this UAB number and information. I was asked to do that. Final thing.
Yeah.
What are ways to effectively reach providers so that more compassion is shown to pregnant people, specifically women of color? Any suggestions, comments you have about that?
So one of the things that I've noticed in the worlds that I work in is that everyone needs empathy and compassion, and that includes providers, right? So, I mean, we are focusing on our patients because they are the priority, their health needs are important, but our providers are people and they have their own lived experience. So I think treating them in a way that is just as sensitive, empathetic, and compassionate is really, really important to building that bridge.
Okay. Alrighty. They are also saying that the ACHN coordinators can help navigate services postpartum. So if you have someone that is a part of that program, please have them reach out to their Medicaid ACHN coordinator.
Absolutely.
Okay, thank you so much again. Great presentation. We are thankful that you were able to join us and share your research. If you have any more questions, there is her email there on the screen. And thank you.
Thank you, everyone.
Okay, we are moving on to our next presenter, Miss Monica Acoff. She is a licensed independent clinical social worker. She received her bachelor's degree and studied master's level counseling at Troy University and at the University of Alabama. She has worked in both community and facility settings, and she has extensive experience with families, couples, and individuals coping with trauma experiences. So let's get her up here so that we can welcome her today. And
Thank you.
Dr. Horan, if you will stop sharing, and Ms. Acoff, if you will begin sharing your screen.
Okay. I will do that. Let's see. Okay. I have to wait just a moment.
You stop first, and then you
Okay.
can-
Great. So first of all, let me just say thank you all for giving me an opportunity to speak to this wonderful group of participants. Super excited about it. Looking at the list of panelists and those who have gone before me, I am saying that I have some catching up to do. I'm very impressed. All that I've heard thus far has just been so wonderful and informative. So I hope that I can keep people awake and be just as informative with my presentation here. So let's see, let's share my screen.
And your camera is moving a little bit up and down. I'm not sure if it's
Okay.
a little bounce.
All right. Let's see. Is that better? Not moving so much?
Yes.
Good
Yeah,
deal.
yes. It's like every now and then, but it's fine. We'll work with it.
We're working with it? Okay. All right. I don't want to make anyone dizzy. Just my speaking could possibly do that. So everyone can see my screen okay? Is it shared appropriately for you all?
It's when you started, yes, we can see it. You just need to start so that we only see what you're speaking on at the moment. Just start the show. Yep.
Okay. Well, there we are. I'm going to resume that. If it's going to let me do that. All right. 1 second. I'm having some technical difficulties. My screen is moving. Can't seem to share the screen appropriately, but we're going to get this together in one moment here. All right. Let's see. Share the correct one. All right. That is still. Are you all seeing just what I need you to see here?
No, it's in presenter mode. So.
Okay. Perhaps I need to close some things out. Let's see. Okay. And I had enough time to try to practice this, and I thought it was ready, but here we
It's
are.
okay. We all practice. We had difficulties this morning. That is technology.
Okay. Let's try this again and see. Make certain that I don't have several things open. Okay, good deal. And seeing that everyone's having to wait for me for just a second, I really hope that this is informative and what they're expecting for it to be.
It's okay, it happens.
All right. Still in presenter mode. Let's see.
Can anyone tell me what to tell her to change that? I don't know how she, let's see.
Can you hear me?
I can't. Yes, I can hear you.
Okay. In the slideshow at the top of the screen, can you see it at the top where it says show taskbar, display settings, and end slideshow?
I do not.
Okay. You can just click on the arrow to the top right and just close it out. And then reopen it, and I can show you a much faster way.
Okay.
Okay, right there. If you go to the bottom of your screen to the right, you will see where it says, I think 69%.
Oh, to the right. Okay.
Yes. Okay. So back over to the left and the first icon, click on that. Okay. And once you click on that, it should change to the presenter mode. Can you click it again?
Okay. I wonder if it's something to do with me here.
Yeah.
There we are.
Okay.
That
Thank
is what we need.
you.
You're welcome.
Thank you.
Welcome.
Great minds. Okay. Again, I'm Monica Acoff. You all probably have forgotten me, seeing that it took so long for us to get started here, but we're going to get right into it. I'm with PAD Counseling Consulting Services, and we have the pleasure of working with a number of patients or clients with a variety of different mental health concerns and issues. And so dealing with grief and loss is one of my areas of specialty, seeing that I often receive referrals in that area. So this is something that is near and dear to my heart as I speak through it. I'm wanting it to just flow pretty quickly and easily for you all. And so we're going to go through just the goals of this presentation. We really want to try to gain a deeper understanding of what is grief, recognizing the myths and the reality of grieving, and how to assist clients or patients in the task of mourning, and also identify how healing can be a part of the lifelong grieving process. And that is a challenge for a lot of us. So we're going to get right into it here. When we think about what we know about grief, it is the most challenging, human experience. So oftentimes we think that if someone's grieving, then they're going to go through these stages, and these stages are, pretty linear. And really and truly, it is a roller coaster ride for most people. And so how we engage with grief, it is really determined sometimes by who we are, our culture, the way that we've experienced grief in our family. And so it can be based on our spirituality or our religions. So there are a number of ways that we can definitely experience it, but it's very important to know that it's a unique process. And so we're going to talk through, some of those myths that people have and how people should grieve. The very first one is wanting to understand that there's a right way to grieve is often a myth out there. People have their ideas of how long someone should sit in a particular grieving stage or process. And so just remembering that some people are going to grieve in their own unique way again. So those responses can vary very widely, depending again on your culture, and it's person to person. What is helpful in the moment may not be helpful in the next moment. So just kind of being able to flex and bend with someone who's dealing with the loss of an infant is very important. Another myth is that grief should resolve after a certain period of time. And this is one of the most challenging ones again. I think that grief within itself, when we're dealing with an infant's loss, is extremely painful and hard and challenging, but it's also very challenging for the people who are attempting to support in this. So just remembering that there's no time period. So though someone may have lost their infant 10 years ago, that doesn't mean that they still won't have those moments when it is a bit overwhelming for them and a challenge for them. It does lessen with time. That is what we would hope would happen. However, if someone is, feeling like that moment just happened to them, then we want to be able to still support them. It doesn't end just because years have passed. So that is something that we want to make certain that we remember. Again, just going through the distinct stages of grief. Most often, we think about those stages that have been defined by Kubler-Ross, where we talk about anger, and we talk about there being sadness or depression. We talk about bargaining, we talk about accepting, and we talk about denial. So oftentimes we think that if someone's grieving, that they're going to take those stages and they're going to eventually get to the one stage where we all want them to be, which is accepting their loss and being able to move forward. However, there may be a day when someone has moved forward and they feel like they're in a place of accepting, but then they go back to feeling very sad about that loss. And so just being able to support someone in that is very important as well. So the grief experience in the same way, it's the same way across all cultures. And we know that that can't be true and can't be for certain, as we, again, all come from our own unique places from a cultural perspective, from our families. The way that we really process our emotions can be different. And I know the previous speaker spoke about emotional intelligence. So the way that one group may express sadness may be completely different from another. The way one group expresses anger can be completely different from another. There may be individuals who do not express emotions at all. So we really want to be careful to not assume that the way that I grieve should be the way that the person that I am working with, serving, assisting, is going to grieve as well. So taking that into consideration is extremely important. And we often sit in the idea that grief is intense sadness. And so it's hard for people to move past that. But sometimes you can find, even in grief, especially when we get to that place of being a bit more accepting of this is our life without our infant, then we may be able to find those moments, those nuggets of joy and hope, and seeing that the world is still moving. And so our worldview has changed. That doesn't mean that we've forgotten our infants in any way. However, we don't have to sit in a place of sadness to say that we are still grieving that loss. So moving on is a betrayal of the deceased. So oftentimes when parents lose an infant, they feel that the idea of having another child is forgetting or dismissing or not honoring their infant. And so they feel like there is a certain time frame that perhaps they should do that. Others in their lives may also share that with them. And so, or maybe encourage them to, move forward with life. If they're in a position where they can conceive again, they may encourage them to go ahead and do that. And so the idea of someone having another infant can seem like a bit of a betrayal after they've lost one child. And so going on with life and seeking happiness does not mean that you've forgotten or stopped loving the infant that you've lost at all. And advice is the best way to help someone who is grieving. That is one of the most challenging things for us or for myself as a clinician, is to not give that advice, even though it may come from a good place and good intentions. But the idea of telling someone, again, how they should move forward, the things that they should do, where they should be in that grieving process, it can really cause them to spiral backwards. So we really want to be careful to not advise a grieving individual as to how they should move forward, especially after losing an infant. Allowing them to be able to process that in their time, in their way, is going to be very important. So I wanted to kind of talk through the grieving process from the acute grief and the complicated grief into integrated grief perspective. So when we talk about the acute grief, it's immediately after the loss. So most people, when someone's lost an infant, they have this expectation of, okay, there's going to be this moment of grief. And so we're watching, we're very much monitoring how they're doing. That's when everyone's checking in, everyone is there supporting. And so at that time, acute grief is, again, immediately after the loss of an infant and for months afterwards. It may be normal to have those intense feelings of shock and distress. And these symptoms will slowly diminish as time passes. And that is acute grief. But when we get into the complicated grief, it is when these symptoms of acute grief they never seem to go away. They just seem to linger a bit. And it can be very hard for parents to move forward. They may constantly yearn for their infant and express guilt about what they thought they could have done differently or should have done differently. And making it a big challenge for them to move into accepting that loss at all. So sometimes that grief is not truly resolved. Again, grieving individuals will enter the lifelong stage of integrated grief. At this point, a parent has come to accept the reality and resume daily life activities. This doesn't mean that they no longer miss their infant or love them any less, but acute grief may show itself again, especially around those particular days, the holidays, the birth of their infant, maybe the day that they realized that they had conceived. All of these things can kind of bring them back to acute grief. And so it's important to recognize that we can integrate the acute grief with the complicated grief, because complicated grief is ongoing and acute grief is something that may come back again and then we resolve it, but that doesn't mean that we've stopped the grieving process. Again, losing an infant can be a lifelong grieving process for someone. So we want to talk through the task of mourning, which can be a bit of a challenge. And so when we think about that, after an infant's death, friends and families face the complicated emotions and the new reality that the hopes and dreams of the future of their infant, they no longer exist in that way. And so the task of mourning, we want to describe how to adjust to loss in a healthy way. And this is where we get into the healing component of it. So the task of mourning may be completed in any order. They may be revisited multiple times, and it may be completed at any pace. So again, we go back to the importance of not giving that advice of how things should be if someone's grieving the loss of an infant. We want to remember that this mourning can happen in any order. It may be revisited multiple times and is at their own pace. So the first task of mourning that we kind of want to explore is accepting the reality of the loss, accept the loss both intellectually and emotionally, and recognizing the significance of the loss. And so this goes back to our ability to identify our emotions, what we are truly feeling, emotional intelligence, and being able to act accordingly in that. So if we are angry, then it is okay to express that anger. It doesn't mean that we need to push that back. It is being able to, again, accept the reality of the loss, intellectualize it, and express it emotionally, and recognizing that it has been pretty significant, that this isn't something that you're expected to be over in a month or a year or by anyone else's terms or standards. Task of mourning number 2, we want to say process the pain of the grief, name and make sense of your emotions. Let yourself feel these emotions rather than trying to bury them. So oftentimes when we are grieving the loss of an infant, because our support system, they may not have, had an opportunity to meet the infant, the experience with the infant, and therefore we feel that we need to go ahead and move past it. So we may not talk about it. there may not be an opportunity to share what we're feeling, that pain of that grief, because we're under the understanding that, okay, no one has experienced this the way that I have. And that's called a phenomenological experience. Though they know that there has been an infant death, the way that we process that is going to be completely different, because again, it's a unique and individual way of processing. So trying to adjust to a world without your infant, making practical changes, adapt to changing self-identity and worldview is a challenge. As a parent and expecting and going through that process of feeling your baby, again, expecting all of these wonderful things, and to lose that infant, your worldview has changed, of course, but your identity has changed, especially if this is your first child. If it is your second, your third, you're still not a parent to a second or third child. You're not a parent to a first child. And so the idea of just having to make all of these changes at once in your thoughts and your emotions can be a huge challenge. So we want to make them very practically. There again is no specific way or time frame or pace that you should use in order to get to this space or this task of mourning, of changing your worldview and understanding that your self-identity has changed. But when you're understanding that, then you recognize that life can move forward in a healthy way without you forgetting the infant that you have lost. So we want to make certain that we're supportive in that. So the task of mourning number 4 is remembering your loved one while moving forward in life. Create a place for your loved one in your heart that leaves room for the possibility of having another opportunity to parent. Find balance between remembering your infant and moving forward. So in this particular mourning task, I talk a lot with individuals about thinking of ways to honor their infant. If it's naming a star after them, perhaps you have, a particular date that you want to remember. Again, it could be the date that you realized that you conceived, or it could be the date of delivery, or it could be all of those dates. And you taking the time to honor your infant. So you're moving forward in life, but remembering the infant that you've lost. Not feeling that you have to just kind of move forward and not talk about them. Also in that remembering, as we are supporting our clients or patients who are dealing with such a loss, it is good to talk through with them their experiences with pregnancy, delivery, also naming the infant, depending on when the loss happened, naming the infant and using that infant's name when you speak of them versus calling them an infant or your baby, but really remembering them and honoring them as if they existed. So not pretending as if they didn't exist in an effort to help someone move on. So this is another task of mourning, is remembering. So we think about healing while grieving. Is it even possible? Again, grieving an infant's death can be a lifelong process, but healing from it is possible. And so we're going to talk through how we can best promote that healing progression as clinicians and those who are supporting a parent or parents or family members who are dealing with the loss of an infant. So first thing is embracing, not rejecting our emotions. And that can be a bit of a challenge. So when we are, again, when we're sad, it is okay for us to express that sadness. And how do we support someone in that? We listen. We don't have to share advice. Sometimes silence is best because it is such a challenge when someone is grieving for us to not say something. Sometimes it is best to just listen, allow them to express their emotions and not try to push them away. Acknowledging them, being aware of them, and then acting on them appropriately. And so as a support to someone who is grieving the loss of an infant, being in that space with them, sometimes just being silent can help. So living normally again, that can be a bit of a challenge as well. But again, we want to pace ourselves. There is no, again, no time frame for getting back to something normal, a new routine. It can be very helpful in that. And so doing things that we are supposed to do can be hard when we are grieving, especially if we're sitting in that acute grieving process a bit longer. It can be hard to get up and make your bed. It can be hard to get up and perhaps start back working again. And so trying to get back to something that is more normal in your life can be very helpful in the grieving process. Backing up again, understanding that we are healing while grieving, because grieving can be a lifelong process, especially when we're talking about the loss of an infant. As the years pass, we are still going to be remembering that infant that we've lost. And so just being able to add something normal back to your life slowly, very methodically, is very important. Healthy living. So then the question is, how does this help with healing? Sometimes when we are grieving, we don't do certain things. We don't eat. We're not sleeping well, or maybe we're overeating, or maybe we're sleeping too much. And so to try to, again, get back to something normal, a healthy living, healthy lifestyle can be helpful in that. So planning to eat something at a certain time each day, planning an exercise routine to try to get you up and moving. These are ways that we can support our clients or patients who are in that grieving process, encouraging those things for them, asking if they've had something to eat can be important. I've had patients that I'm talking with, and I'll ask, well, when was the last time you ate? And they have to think about it. And so to be able to really help them with stopping for a moment and getting back to something healthy. When was the last time you slept? Or asking, how have you been sleeping? Again, something that they most often have to think about, because sometimes that grieving process can swallow them whole, and we don't want them to have to sit in that. And so finding balance in life again can be a bit of, again, a challenge. And so how do we help them with finding that balance? So because grieving is something that is ongoing, we don't want to say, well, the best way to find balance is to get to a place of acceptance. If someone is spiraling into sadness, then the way we can support them in that is maybe sharing with them the importance of feeling that emotion at that time, but not staying there. So yes, you are sad. Yes, you are angry. Perhaps giving yourself some time to sit in that can be very beneficial. The balancing of it is, again, not allowing it to just gobble you up. So you're feeling sad. I'm going to give myself this time to feel sad, and then I'm going to do something refreshing to balance this out. Then we talk about counseling, therapy. This is not a plug for TAG, but it is important sometimes for individuals to be able to speak with someone outside of who they're seeing on a regular basis because they feel so misunderstood, or perhaps there are things that they want to share that they're just not comfortable sharing with a friend or with a loved one. Perhaps they need that stranger, that perfect stranger that they can just let it all out with, express those emotions, and it is a safe space for them to do that. And safe spaces include people, safe spaces, include places, and they include activities. And so sometimes going to therapy can help you with identifying those safe spaces and being able to, again, heal while in that grieving process. Managing those unpredictable moments. So how can we help our clients or patients with managing those unpredictable moments? Again, because it's unpredictable, you can't plan for it. But what you can do is try to help them identify when things will become more of a challenge for them, possibly. Those dates. Dates are very important when someone is grieving. So it could be, the smell. It could be hearing a baby cry. So just kind of helping them with identifying who they are spending their time around, and what could possibly be some triggers for them. And so when those unpredictable moments happen, that does not mean that they need to suck it up and figure out how to move forward because they're in a space where no one else is emotional. When those unpredictable moments happen, they need to be allowed to grieve in that moment. And again, we get back to finding that balance. We've grieved in that moment, and now we figure out a way to try to move past that and do something that maybe is outside of grieving acutely in that moment. But again, grief is a lifelong process, particularly for someone who's lost an infant. And that is my presentation with questions and answers from me. I'm answering. You question if you like.
Okay, lots of hearts and hand claps. That was great. You did a wonderful job. I thank you for that.
Eventually.
No, doesn't matter.
Thank
It's okay. I
Thank
wanted to
you
say
all.
personally, before we get to the audience, I am not grieving an infant loss, but I feel like I just had a mini therapy session, and I'm thankful for you and all the tips and things that you gave. And that we need that. So we're all grieving something. But to the audience now. Okay. First question, have you encountered a parent who acknowledges the loss, acknowledges the feeling of grief existing, but they may be masking those feelings or acknowledgement, but asking you to support them in getting through it? If so, how do you handle that? What do you suggest?
So can you ask that again? Especially, that was a long question, the last part.
So it seems like they acknowledge that they have a loss.
Mm-hmm.
And that they're grieving, but they're masking their feelings. It seems like they're just not quite, they want you to support them, but I think they haven't fully accepted it all. So how do you handle it and get them to where they need to be?
Okay. So again, with grief, I really talk through with people that there's awareness. So we're aware of the loss, and then we get to a space where we can acknowledge that loss, but what actions do we take to fully grieve that loss? And so sometimes people are in the awareness and acknowledge stage. They're not quite ready to do anything in that moment. And so that's why we back up a little bit in the presentation. Sometimes silence is okay. Sometimes just allowing them to let it out, be that space for them to be able to share where they are. Over time, they will get to a space where they're ready to take some action. So it is okay for people to sit in that space of awareness and acknowledgement, just not quite ready to take any action just yet.
Okay, thank you. Would your services be available for Alabama Medicaid? There's the Alabama Care Network serving patients in the Auburn area who are in need of grief counseling following loss.
We are really hoping that we will be ready for that October 1 of
Okay,
this year. So
great.
yes.
Okay. I have a comment and then another question. Giving parents of miscarriage or fetal death during the pregnancy, even early, the permission to grieve. That's their comment. They say so many are told that since the baby was never quote unquote born, they
Yes.
shouldn't grieve it as a loss of a child, and they need to be told that it's all right to grieve. And I know that you and everyone else will agree with that, you know.
Yes. Yes.
How do you support a patient suffering loss when you've suffered a similar loss without being emotional? How do you get them through their loss when you may not be completely over your own?
A very, very good question, and it's something that I've personally dealt with recently, having lost a loved one and immediately receiving a referral for someone who was dealing with loss as well. So the first thing that I did is I offered that transparency. So you want to do that. You want to let them know that you are dealing with a loss as well. And it could be something that is similar. But again, we go back to it's a phenomenological experience. Though you've experienced a similar loss, the way that you manage that, the way that you even viewed it could be completely different from the individual that you're speaking to. So again, being transparent and acknowledging that I'm dealing with a loss myself. And so there are no surprises there, but also doing those checks with yourself before you encounter someone or engage with someone. If you already know that you're about to engage with someone who's dealing with a loss similar to your own, going ahead and processing that within yourself as best as you can before you engage them can be very helpful. And again, starting out with that transparency of, I'm dealing with a loss as well, because you don't want to, I say, and I've said this to individuals, I don't want to take your tears.
Right.
This is your time to grieve, not my time to grieve. And so, but I'm being transparent to let you know that I'm dealing with a similar loss that is not yours. It is not like yours. That can be that advice of, hey, I know what you're going through.
Right.
You really don't, because again, it's a unique experience.
I like that. I don't want to take your tears. Okay, we have another question. Is there a cutoff for the number of sessions a grieving mother or father can receive?
No, because again, it's a lifelong process. And so I have dealt with individuals who they may be with me for 6 months and then they feel like, okay, I'm better. I want to stop a little bit. Maybe I want to taper the services for a while. And then, so we may meet once a month or we may meet every 2 months and we're kind of doing those check-ins. So no, there's no limit.
Okay. This was specific to a certain insurance, but do you accept all insurances? Let's say like Blue Cross and TRICARE, you know?
I do, and we're getting other clinicians on board to do all of those insurances as well. So yeah.
Great, thank you. Any more questions before we let her go and go to lunch? Anyone else? They're still clapping for you and Cindy.
Oh, thank you. Oh, y'all are so patient and wonderful. Oh my goodness, it took me forever, I know, to start speaking. So
it is okay. It was
I
well worth
appreciate
it. We were thank you. Okay. Well, we will let you go and we will let everyone else go to lunch. Thank you all. I made an announcement in the chat box that the presentations will be available after the event ends. I'm also going to bring all the panelists back up over lunch into another feature so they can share their contact info because people are asking for that also. So thank you all for your questions and we will see you in 30 minutes, 12:45. Thank you. Welcome back, everyone. I hope everyone had a good lunch. We are about to get started again. Okay. And thank you all for your participation and attention thus far. We are down to our last two speakers. Our next speaker is Ms. Megan Aucutt. She joined Healthy Birthday, Inc. and Count the Kicks as the Associate Director of Programs in 2019, and she became the Director of Programs in 2021. She has a bachelor's in history and an emphasis in global health. That is how she started her over 10 years journey of experience with nonprofits and governmental work. She oversees Count the Kicks and the Healthy Birthday Inc.'s organizational grant program and works with the Count the Kicks state partners to ensure implementation of the program in each of the partner states. So thank you today for joining us, Megan, and sharing all the great things that Healthy Birthday Inc. is doing with Count the Kicks all across the country, and particularly in Alabama.
Yes, thank you,
Let
Samille.
me get you set up appropriately here so everyone can see you in your presentation.
Yeah. Spotlight, perfect.
Okay.
And you can see the full slide deck, not the two sides.
Yes. I can see all the cute baby saves.
All the cute baby saves. Yes. Well, thank you for that introduction. Welcome, everybody. Welcome back from lunch. I hope you got to stand and stretch and maybe do some yoga or something. I know this is a heavy day, both just online and also the topics. So I really appreciate this opportunity. I appreciate you being here and being present. Like Samille said, all these cute baby faces, these are just some of the Count the Kicks baby saves that we know about. This is why we do what we do. We're gonna flip topics a little bit where we're going to talk about stillbirth, which is the loss of a baby after 20 weeks of pregnancy and the prevention of stillbirth. And I know that it goes in line with infant mortality, but it is defined separately. So like Samille said, my name is Megan Aucutt. I'm the program director at Healthy Birthday, which is the nonprofit organization that created Count the Kicks, the evidence-based stillbirth prevention program that you're going to learn all about today if you haven't already. I hope that if you do know about Count the Kicks, because we've been in the state for a couple of years, that you learned something new today. And if you've never heard about Count the Kicks, that you walk away just feeling empowered and excited to be sharing this information in your community. My contact information is there, and Samille also put it in the chat for you. I love hearing from you. I love sharing all of your great outreach and ideas with the team back in Iowa, where we're based. So feel free to always reach out to me and ask questions as we go along too, and I'll answer them at the end. But I'm excited to be here today, and I have no disclosures. And then just thank you for this opportunity from the Alabama Department of Public Health, Gift of Life, and Birmingham Healthy Start. And then a big shout out again to the Alabama Department of Public Health and Oral Health Office, Dr. Tommy Johnson and his team. Because of a great partnership with you all, we can provide these types of webinars and outreach. The material that you're going to hear about today, the material you can order, all of these things are brought to you for free because of this partnership with Alabama Public Health and the Oral Health Office. So I'm excited to share that with you all today and be here coming to you from Iowa, where it's about 70 degrees and beautiful.
Nice.
Yes. So let's kind of set the stage a little bit about stillbirth and data. The previous presenters were phenomenal. I thought that it was very informative, educational, learning about maternal stress and toxic stress and everything, and infant mortality and grief. And so when we talk about stillbirth, where I mentioned earlier is the loss of a baby after 20 weeks of pregnancy, we know that families are 6.5 times more likely to lose a baby to stillbirth than to SIDS. So on average, we lose around 22,300 babies a year to stillbirth, and then about 20,000 babies to infant mortality. So what I want to highlight in the fact is both are devastating and tragic. And this is why this type of conversation is so important, that there's 300 plus of you on this call today is truly amazing and wonderful. But what I want to do is highlight the fact that we need to be talking about stillbirth just like we're talking about infant mortality. We want to be talking about count the kicks and fetal movement monitoring, just like we're talking about SIDS and back to sleep and the importance of laying your baby on its back and having a fan going. That's what I want you to take away today, is to be able to be comfortable talking about stillbirth and stillbirth prevention best practices with the expectant parents you serve. So across the United States, 1 in every 173 pregnancies ends in stillbirth, and the racial disparities persist and exist are large. Native Hawaiian or other Pacific Islander pregnancies, 1 in every 94 pregnancies will end in stillbirth, and Black pregnancies, it's 1 in every 97. Indigenous pregnancies, 1 in 128. So you can see there the Native Hawaiian, the Black pregnancies, the Indigenous are 2 to 3 times more likely to experience a stillbirth than their white counterparts in a lot of parts of the country, including your home state of Alabama. So when we look at the data here of stillbirth rate, it's 8.85 per 1,000 live births in Alabama. 1 out of 113 pregnancies in Alabama ends in stillbirth. Thinking back to the previous slide, I had said nationally 1 in every 173 pregnancies ends. So you can see the sharp difference there, which is also highlighted in that graph. So you can see it's a little blurry, but the Alabama is the yellow bar, Iowa is the red, and then the national is that teal line. And so this goes through 2020 for Iowa, and I'll work with Samille and her team to get more of the data for 2020 for you all. But approximately the 5-year average, you lose around 527 babies every year to stillbirth. And then the disparities that exist, this is the data that we have received through vital records at Alabama. We have white, and then we have the Black and other races as well in there. So you can see the big difference between the two. And so we center equity in everything that we do. I'll talk about that a little bit later. I'll talk about health equity and how we can have an equitable conversation around fetal movement monitoring. But it's really important to be able to have these conversations and to address these disparities and to speak truth and to have partners like the Alabama Department of Public Health and all of you on the ground that are going to take this information and implement it to go forward. Okay, sorry, I saw Samille for a second, so I was like, oh, we have a question already. Perfect.
There were people saying hold on. There were people saying they could not see you. They could not see your presentation. They couldn't read the PowerPoint. So I was trying to.
Okay.
Can someone let me know what you see now?
Yeah. Are we good now? Do you want me to keep going or wait a second?
Yeah, just go ahead. Okay, they said good.
Okay, thumbs up. Perfect. Awesome. So we got a little bit of background on the data, right? 1 in 173 pregnancies across the US, 1 in 113 pregnancies ends in stillbirth. I want to just take a moment to talk about the rural aspect of this, because Alabama has a lot of rural areas, much like Iowa. I think you've had a lot of birthing center closures, just like Iowa. And so I wanted to kind of set the stage of how Count the Kicks can also help bridge that gap in those rural areas where there's not a lot of obstetric or maternal health or birthing center care. So by 2018, over half of rural US counties didn't have a hospital that provided obstetric care. The epidemic of closures is only growing worse, creating maternity to birth deserts. I'm sure you're seeing this in Alabama. So in rural areas, it's a lot more common for family physicians to deliver babies than in urban areas where it's more common for OBGYNs and midwives to deliver. We also know that the loss of hospital-based obstetric services in rural areas is associated with increases in out-of-hospital births and preterm births, which may contribute to poor birth and infant health outcomes. And so one of the things that I want to make sure we get across today is whether you're working in a federally qualified health center or a large hospital or a home visitor, you can take this and integrate it into your workflow, Count the Kicks, in a variety of different ways in any of those settings. So I liked this quote here where the decreased access to birthing units can pose a dangerous risk, as the United States is currently experiencing a sharp increase in maternal morbidity and mortality compared to other developed countries. So we know that access is critical, right? We know low rates of prenatal care through pregnancy are associated with increased adverse outcomes for infants, including stillbirth, premature birth, low birth rate, being small for gestational age, and having higher rates of admission to neonatal intensive care units. How can a stillbirth prevention fetal movement monitoring program help bridge the gap a little bit? I'm going to talk about that here in just a minute. But for those of you who aren't that familiar with Count the Kicks, it is a highly effective evidence-based stillbirth prevention program. We developed an early, proven early warning system for expectant parents. We're saving 1 in 3 at-risk babies in Iowa. That's what we want to see happen in Alabama. And I'll talk a little bit more about that data and research in just a minute. But before we do that, I wanted to share a video that does a really good job of sharing how fetal movement monitoring and Count the Kicks and mHealth technologies, so like the use of our app and the use of this, having this kick counting conversation with your patients and your parents in your communities, how that can play a role, especially in those rural areas. So I'm going to play this video and hopefully I remember to share my sound.
With the increase in hospital labor and delivery closures throughout the U.S., the lack of maternal health care is greatly impacting rural Americans. It can result in several adverse maternal and infant outcomes, including premature birth, low birth weight, out-of-hospital births, maternal and infant morbidity and mortality, and increased risk of postpartum depression. If the closest hospital does not offer labor and delivery services, a pregnant woman may have to travel to a different community many miles away to deliver her baby.
If that is what's keeping you from going in and checking on your baby, hours and minutes matter. Once you notice, go in, don't wait.
We have a solution.
He's wearing the cleats to help promote healthy pregnancy and prevent premature death.
From Sunday Night Football,
a free app a mother says helps save her baby's life,
to Good Morning America, the Count the Kicks program is making headlines.
We have a healthy baby girl and we could have had a burial instead.
Count the Kicks is an evidence-based stillbirth prevention program that teaches expectant parents the method for and importance of tracking their baby's movements daily in the 3rd trimester of pregnancy. A study recently published in BJOG, an international journal of obstetrics and gynecology, shows the Count the Kicks stillbirth prevention program helped lower the stillbirth rate in Iowa by more than 30% in the first decade of the program. This happened while the rest of the country remained stagnant. How do we save lives? We host community baby showers, webinars, and trainings with partners. To break down barriers to access, our free app is in 16 languages with a new web-based kick counter and bands for moms who don't have smartphones. For these rural moms, Count the Kicks education and awareness made all the difference.
I want other moms to know that the importance of using the Count the Kicks app and how simple and easy it is to use to count your baby's kicks and monitor the amount of time that it takes your baby to get those normal kick counts. And I also want other moms to know that it's not just is your baby kicking and moving, but is your baby kicking and moving in the same pattern and in the same amount of time? Because had I not paid attention to that and mentioned something to my providers, Kembra's outcome may have been different because her kick count had changed. The pattern had changed. It was still a normal pattern, but it had changed from what was normally hers.
I want other moms to know that kick counting is one of the simplest things that you can do in a pregnancy, and it has great reward. Everett was born back in March when I noticed a reduce in his fetal movement, and his kicks were just not normal. And it's so easy, it's so simple to do, and it has brought so much joy into our life. So if I wouldn't have spoken up back in March when I was nervous about COVID and I wasn't sure what to expect going in for a test and having him early, we wouldn't have this joy in our life right now. So I would just like to encourage other moms to just take the few minutes, 10, 15 minutes that it takes to kick count throughout a day. It's so simple and so worth it.
The free Count the Kicks app is a data download for mom's intuition. And when a baby's movement changes, time is of the essence.
If I hadn't been using the Count the Kicks app every day, I likely wouldn't have known that something was wrong. And we might not have known this beautiful, confident, vibrant little girl that we know today.
When you give the gift of telling someone about Count the Kicks, it costs you nothing but can truly save a life. One conversation can have a powerful return. You're affecting our trajectory and saving babies. There are more and more babies saved each year.
It's been a very impactful program here in the state of Iowa and certainly for our practice as well. I would ask all providers in the obstetric world, whether you're a generalist, OB/GYN provider, whether you're a midwife provider, lay midwife, otherwise, whether you're a high-risk maternal fetal medicine provider like myself, to take advantage of the information that Count the Kicks has available to you to provide your patients and help everyone decrease the incidence of stillbirth, one of the most tragic occurrences that we all have seen and experienced, because it's still happening in too great numbers. It needs to become a rare event.
Together, we can save babies and improve outcomes.
So in a little bit, we'll talk a little bit more about those materials that you can have and how you can utilize those, whether you're a home visitor or you're a rural healthcare clinic. But one of the things I want to turn to now is a little bit more about the evidence behind the program, because it tends to be one of the most often asked questions is around this next section that I'm going to go into. So you heard me say a lot about Iowa, where I'm based, where we're founded. What's really important about that is we were founded by 5 central Iowa women who all experienced stillbirth or infant loss in the early 2000s. They didn't know each other at the time of their loss. They got connected through friends and pastors. And as they started grieving together and meeting for coffee, they were sitting there thinking, wow, this is a lot more common than people think. Here we all sit with relatively very similar stories, yet we're getting told things like it's like getting struck by lightning. So long story short, a couple of them were at a public health conference, these founders in Iowa. They were at a public health conference where some researchers out of Norway shared information on a study that they had done, where when they educated in the study, when expectant parents were educated on the importance of getting to know what was normal for their baby in the 3rd trimester at 28 weeks, they were handed a pamphlet in this study. When they were told to get to know what's normal for your baby, and that's key, we're going to highlight that a couple different times, that the stillbirth rate among this cohort of women decreased around 30%. And so the Iowa women, the lost moms, the founders had said, wow, like that's amazing. Kick counting has been around for a long time, but the tools and resources for providers and those that work with expectant parents, those needed to be created. We needed to create an empowering, self-advocacy, bright, colorful campaign that encouraged expectant parents to get to know what was normal for their baby and gave them the tools and resources of how to speak up to their provider if they noticed a change. So that's what they did. They came back to Iowa with this study. They looked at other research on the importance of tracking your baby's movement in the 3rd trimester. They worked with Iowa Department of Public Health and a local marketing company, and they created the bright, colorful program that you just saw in that video. And so this is one of the studies I highlight in all the presentations I do, because it's truly the one that started it all. You can read the full study. It's not long on our evidence page on our website, as well as look at other research on our website. So the BJOG study that was referenced in the video, that was just published this last year through the British Journal of Obstetric Gynecology, that looked at Count the Kicks implementation in Iowa and looked at surrounding states that didn't have a stillbirth prevention program at all, and looked at what was done, the Good Morning America video, all the materials going out the door, the app downloads, which showed a 32% reduction in the stillbirth rate in Iowa between 2008, when we were founded, to 2018. That's the time frame this study looked at. So we've seen that 32% reduction in Iowa, and that's what I talked about earlier about that saving 1 in 3 at-risk babies. That's what we want to see happen in Alabama. We also had research published in AJOG, which is the American Journal of Obstetrics Gynecology, that talks more about our app data, which I'll talk about here in a minute. But this is the 32% reduction in Iowa, just in a visual graph form. So in 2008, when we had the soft launch of Count the Kicks to 2008, that's when we saw that 32% reduction. We've maintained that downward trend. That's the type of reduction and trend line we want to see happen in Alabama. In the first 5 years of the program, we saw about a 39% reduction. on the stillbirth rate of African American individuals in Iowa. So this is what we want to see happen there, and we need your help to do that, because together we have the potential to save 167 Alabama babies from preventable stillbirth by implementing this program and sharing this with your expectant parents. And we have 2 beautiful babies that we know of right now. When I talk about our baby safe stories, these are individuals that just come to us. We don't seek them out. They say, they contact us on our website or through their provider contacts us and says, hey, I knew about Count the Kicks. I was handed a poster, or I saw a social media ad. I knew how to track my baby's movements. I knew when to speak up, and now my baby's here because of it. So baby Aspen, who was at the proclamation signing, which I'll talk about in a minute, but you saw it in the little commercial break that Samille had done. She was there, and baby Thatcher. So both baby saves in Alabama. I know there's more out there, but these are the ones that have contacted us. Aspen in particular, her mom knew about Count the Kicks because one of Samille's contractors, MCH contractors, I never get the right terminology, so you can put it in the chat, Samille, but went to one of the clinics in their county and shared the brochures and materials that I'm going to tell you about here in a minute to the providers. And Aspen's mom's doctor, her OBGYN, was just floored by the campaign and the program and said, absolutely, we'll do this. Aspen's mom has shared her story multiple times on news outlets and things like this, but had said it was because of my doctor, because she handed me the brochure and she told me every single time I saw her to make sure I was counting my baby's movements, is when I realized I did have a delay. She wasn't moving like normal. So I went in and found out baby needed to get here sooner rather than later. And she was born totally fine. Not early or anything. So that's kind of her story there. And you can read all these baby safe stories on our website. They're great to share too with your parents. One of my favorite parts of any presentation I do is, because I know this is a heavy topic, I want to take a couple moments and give you time to order the materials. They're free. Like, we have this phenomenal partnership in Alabama with the Department of Public Health, where you have no cost to have these life-saving posters, brochures, app reminder cards. So I'm just going to take a couple moments. I'm going to let you multitask. I'm going to play a fun song, and you're going to go to countthekicks.org, which I hope, if Samille can, put it in the chat. If not, you can do it yourself. Click on order materials and click on the state of Alabama and fill your shopping cart. We also have these amazing oral health bundles there that I'll talk about in a minute, but I am going to do this. I'm going to play Happy by Pharrell Williams, who we all love, I'm sure. And stay here, come back, just give yourself 2 minutes to go place an order. I'm also going to do a drawing for a gift card. So go ahead and do that and come right back. Just give it a second. It's a little delayed. Can't remember.
It might seem crazy what I'm about to say. Sunshine, she's here. You can take a break. I'm a hot air balloon that could go to space. With the air, like I don't care, baby, by the way.
I'm not sure what that noise was, but I'll keep going in case that was like my thing to keep going. But go ahead and multitask, order the materials. You'll have another opportunity to do that. Anyone that orders today during the session too will get entered into that gift card drawing. And we'll talk a little bit more about how you utilize these pieces, but there's brochures, there's app reminder cards, there's posters, there's at-a-glance materials for if you maybe work with a refugee population or a population where English is not their first language. It's a lot more picture-based, that type of thing. The other thing that I wanted to talk about when we go back to the research side of things, and one of the #1 questions I get is, well, 2 actually, is this just going to increase calls to my clinic? Is this going to increase visits to the health system or triage? And is this going to increase anxiety in my patients? And I want to address these questions head on because I think some people might be thinking them, but I also want to let you know I understand these concerns. I think as individuals and humans, we tend to focus on maybe that extreme or that almost worst case scenario. So then maybe when that doesn't happen, we feel good, right? But research has shown that there is no increase in hospital utilization. We have not seen an increase in C-sections here in Iowa either. There's some research studies here highlighted, and also on our evidence page, you'll find more research around this. But this one quote says from this research study, usually the fetal movement count is reassuring to pregnant women and prevents unnecessary visits. I'm going to share why in just a minute. The anxiety portion of the piece is we have done an app survey of our app users, thousands of app users, and found that 84% of our app users stated that regular tracking was associated with feelings of bonding, and 77% of app users reported feeling less anxious. And so what happens is when you have a highly educated now individual that understands what's normal for her baby, their baby, knows when to speak up and how to speak up. And with the app, now they have data in their hands. They can quantify it. They can say, look, my baby is not moving like normal. I need to be seen. Or look, this is how my baby's been moving, that type of thing. So it gives them that autonomy, that empowerment to understand what's normal for their baby and then when to speak up and how to speak up. And then there's some additional benefits that I don't think we always consider when we're talking about this, especially with today's topics of the sessions today. And, you know, what I think we also think is when somebody comes in with a change in fetal movement, it's an automatic C-section or an automatic traumatic birth. And that's not always the case, right? That's not the case a lot of the time, because it's a way to check on baby. You and the provider in the clinic are doing those additional tests to make sure mom and baby is okay. So other things that can be found is reduction of preterm birth rate. Fetal growth restrictions can be identified earlier. And we also know that women who have stillbirths are at substantially higher risk for severe maternal morbidity than women who have live births, regardless of the cause of fetal death. You're 4 to 5 times more likely to die if you have a stillbirth. So we know, and research shows, due to the low cost and potential benefit, it is recommended. Decreased fetal movement can indicate a need for more evaluation and has the potential to save lives. It's a way to check on baby. When we talk about that connection between maternal mortality and morbidity, one of the things that we have done is last spring, we released a white paper on that connection where we shared real life stories, case studies of women who were using Count the Kicks, noticed a change in their baby's movements, spoke up, and not only was if something was wrong with them, that was found right away, it saved their life as well as their baby's life. So you can read that report via this QR code, which will also take you to all those other studies I referenced. But I think it's important to know, not only do we have a chance to potentially prevent preventable stillbirths, but do we also have an opportunity to save mom's life as well? So I think it's really important to be talking about this non-invasive, easy, free. So you know about the research, you know about the data, you've ordered your materials because you're great multitaskers and you've ordered at countthekicks.org. How do you implement this? So when you get that shipment of materials, how are you going to talk about this with your expectant parents? When are you going to start talking about this with your expectant parents? Well, ACOG recommends beginning counting at 28 weeks. So when you see your expectant parents right at the beginning of their 3rd trimester, that's when you can start talking about this. You can absolutely talk about this earlier to start prepping them, saying, hey, when I see you at your next 3rd trimester appointment, I want you to have started counting your baby's movements. Or maybe you're a home visitor and you see them every couple weeks and not every week in their 3rd trimester. It's okay to have these conversations early, but what I really want to stress is I want you to talk to them about fetal movement monitoring every single time you see them in the 3rd trimester. If they are considered high risk, you will want to have them start counting earlier at 26 weeks. 26, 27, 28 weeks, that's when research has really indicated that baby has gotten into a routine, a pattern that we can easily track and monitor as expectant parents. So what counts as a movement when you're talking about this with your parents, especially those first-time parents where it's like, oh, I don't know, is it fluttery? Like I always said, it was like gas bubbles or butterfly wings, right? It's those rolls, those kicks, those jabs, those swishes, those pushes. anything except hiccups. Hiccups are rhythmic, right? And that's an involuntary movement, so it doesn't count towards the fetal movement monitoring. So when you're talking about this, because we're called count the kicks, there's that misconception, right? It's just kicks. It's any type of movement except hiccups. So being sure to stress that with your parents is really, really key. My second favorite part of the presentations that I do is, because I know we're all good multitaskers, is I'd love for you to take out your cell phone and I'd love for you to download the app. It's completely free. While you're doing that, I'm going to talk to you about how the app works. So you go to your app store, whether you're an Android user or an iPhone user, Apple user, just search for Count the Kicks, search for the little yellow icon and download. How it works is every day in the 3rd trimester, you are going to encourage your parents to count, and you're going to say, pick a time that's easy for you. Pick a time when you think baby's most active. Pick a time because that's when it works for you. Maybe it's 9 o'clock at night and everybody else is asleep, or maybe it's at 2 o'clock in the afternoon when you get a 15-minute break at work. Keep consistent. Whatever time you pick, that's the time I want you to choose. So how it works is you sit down and you focus on baby, include significant others, include siblings, say, hey, let's read a book and count your baby brother's movements. So you sit down. When you want to start with that first movement, when you feel that first movement you want to start with, you tap that footprint. So once you do that, a timer starts. So every time you feel baby move, jab, push, swish, tap that footprint again until you get to 10 movements. Once you get to 10 movements, the timer stops and you see a different screen. On the next screen, you see a graph or an image that says, rate the strength of your baby's movements between 1 through 5, fluttery to fierce. Because what we know and what research shows is not only should we be paying attention to how long it takes baby to get to 10 movements, but the strength of those movements. So once they rate the strength, what happens is they get a graph. They get a very visual representation of how baby's been moving. And after a couple sessions, the graph shows them the average amount of time it takes baby to get to 10 movements, as well as the average strength. So they can visually see how baby's been moving. Should be pretty linear, right? It should be pretty consistent pattern. So that way, if they're counting one day and all of a sudden the graph shoots up because it took longer, that's going to be a cue to parent to say, that's not my baby's normal. My baby's normal for the last 2 weeks has been 20 minutes. And all of a sudden, according to the graph, it took an hour and 20 minutes. I'm going to call my provider. I'm going to work with my clinic and care team to see what they want me to do. Hopefully they encourage them to go in and get checked out. If you're in a rural area where they're with a family physician or they don't always have access to care, have them go to their nearest birthing center. This is where that rural health comes in and that bridging the gap, that we don't want to wait. We want to get checked out 9 times out of 10. Hopefully everything's good. We want to make sure we catch that one time. So now that you're downloading the app, you're going to be able to pull out your phone and say, look how easy this is. Let's set this up on your phone together. You can set up daily reminders within the app, so you don't have to do it in your separate calendar. It's completely free. There are no ads. We're a nonprofit. The only thing that is a pop-up after a second kick session, and that's just a daily message we can control. It's like an educational message. You can review your kick counting history and share it with your provider. So another way to connect the dots with the provider and having that conversation is saying, hey, I'm going to upload this to my MyChart, or I'm going to print it and take it to me with my next appointment. It's in 16 languages currently. Let me know if you have languages you feel like you need it in. I can list them out because that's always a question I had at my notes. But when you get this PDF, you can hyperlink on the 16 languages and it will show you. We have it in Amharic, Arabic, Burmese, Chinese, Dari, English, French, Haitian Creole, Hebrew, Hindi, Marshallese, Portuguese, Russian, Spanish, Swahili, and Vietnamese. That's currently what the app is in. The print materials are in English and Spanish right now in Alabama, but the app is in all those 16 languages. So you can download the history, like I said, monitor the strengths. You can count on the Apple Watch one day, and you can count on your phone the next day, and then you can count on our new web-based kick counter the third day, and it's all connected, it all syncs. So those are just some of the main features of the app that I wanted to highlight, or that's kind of like our hallmark tool. But if you don't have access to Wi-Fi, or you have parents that live in those rural areas where sometimes the data is hard, some parts of the state, and this goes back to Samille's wonderful contractors, we did have some kick counting bracelets that we have, and that is one way that is a very visual reminder to count to. It's got that slider. You kind of saw it on the video. We also have paper kick counting charts in multiple languages that you can download from our website. It's all about getting to know what's normal and being consistent. And then, like I said, we have our app in 16 languages. We have a health equity team that's always looking at our materials, that's always ensuring that we're being as inclusive as possible, culturally competent. We have a social determinants of health survey where we connect people to free and reduced cost resources in their zip code. We work with non-traditional providers, beauty salons, churches, just anyone can talk about this. Anybody can put materials up. We have libraries that order these materials. So we want as many touch points as possible with the parents. So I want them to see a social media ad. I want them to see a poster at story time when they take their toddler. I want them to see it in the restroom at their doctor's office. And then I want them to see it at triage. I want so many touch points. And then I want to see billboard. I want to see all of it. And then I want you to talk about it. We also have a resource on our app called Find Help. This is where you can enter your zip code and find free or reduced cost services near you or near your work, whatever you need. So you can find childcare assistance, doula care, diaper assistance, dentists, all of that is by zip code. So that's on the resources section of the app. Then we recently launched our web-based kick counter, so you can count on a PC. So maybe you can count at work, but you can't take out your phone. Maybe it's in a locker or something like that. Go to countthekicks.org, click on start counting, and it gives you all the options and all the different ways you can count. So that's also, the PC version is also in all those languages. We also have a training that you can take too. So it goes into a lot more detail than I am today in an hour. It's a little over 2 hours. You get to read the Norway research because I know you're all jumping up and down and getting excited to read all about that research, but you can get 2.25 CEs. And because of our partnership with the health department, you can take this training for free. So again, you don't need to like write this down and scribble it down. But when you go to register, just use the code SAVEBABIES-AL for Alabama and take the training for free. And then you get an additional 2.25 CEs. This is what our paper kick counting charts look like as well that I wanted to highlight as some of the resources. So now that you have the materials, you've ordered it, you know about the app, how do you talk about this? And how do you make sure that you're being culturally competent, you're having good health literacy skills? We're going to talk about that right now. So there's 5 ways that I want to share for improving that conversation around health literacy. You're going to be equitable, you're avoiding assumptions, and you're providing this information to all expectant parents, no matter their race, their gender, their religion, their socioeconomic status, their sexual orientation, education level. It's the same information and interaction every single time. You're going to listen and you're going to learn. You're going to ask strategic, open-ended questions about kick counting to not only help assess what the individual already knows or understands, but also how they're feeling and their desires. You're going to say things like, tell me what you know about your baby's movements, or what questions do you have about your baby's movements? You're being clear and concise. You're avoiding long or complex explanations and medical terminology. Consider everyday vocabulary. So I've been using verbiage like fetal movement monitoring and things like that. I would be talking more about what's your baby's movements like, and let's talk about your baby's movements and your baby's kicks and jabs and rolls. And that's the type of language you would use. And you're being honest. This is a hard topic, and we talk to expectant parents about all sorts of things. And so this should be another conversation we should be having, just like we talk about the importance of taking a prenatal vitamin, not smoking, not drinking. I can't tell you how scared I was to have like soft serve ice cream because of listeria and cold meat, but not once was I ever talked about stillbirth. And listeria happens like 0.001% of the time. So we're going to be truthful, right? We're going to be honest. We understand that people are not delicate flowers. We can have this conversation with expectant parents, also by practicing empathy and compassion. And then we're going to reteach. So if the patient displays confusion or a lack of understanding, make sure to correct and clarify. And that's where this webinar and the CE training come into play, where you have this knowledge now, you understand the misconceptions that you might get, so you can rectify that and share the actual education and extra support. This is also why I want you to talk about it every single time you see them in the 3rd trimester, so you can answer any additional questions that might come up or kind of fix anything that maybe got skewed before. So there's a lot of misconceptions out there around fetal movement monitoring. And so I wanted to highlight a couple of the most common ones we tend to get. I'm open to hearing if you guys get any additional ones, if we need to add some to the slide, but these are just some of the ones that we've gotten over the years, that I've gotten when I've done presentations to parents and things like that. My number one misconception I get is, my baby's always active, so I don't need to count kicks. And I get it. I've had 3 pregnancies. I've had a very active baby, and then a baby that took 20 to 30 minutes compared to my 5-minute baby. And so I always say the same thing to these individuals that say this. I say, that's great. A healthy baby is an active baby, but I still want you to count your baby's movements, because it takes the guesswork out of knowing if your normally active baby has slowed down. A change in movement can sometimes happen really suddenly without warning. So it's really important to understand what your baby's normal movements pattern are. Plus, it just takes the guesswork. We're busy individuals. You don't have to sit there and think, was it 5 minutes or was it 15 minutes? Let's just count daily so we don't have to think about it like that. Only those experiencing a high-risk pregnancy should pay attention to their baby's movements. Again, this goes back to those health literacy skills we talked about. You're having the exact same conversation with everybody and anybody. Everybody deserves to know this information. We don't just talk about gestational diabetes or do that lovely gestational diabetes test with certain individuals. That happens with everybody. Same with this. I want you to talk about this with every single pregnant person you encounter. My baby should get 10 kicks in 2 hours, 10 and 2, 10 and 2, 10 and 1. So easy to say, so easy to remember. This is a really common one. And I think this is the one that I probably get the most questioned on. And there is research on why. I'm going to talk about why this is a misconception. 10 and 2 is outdated. What the research now shows is that people should be getting to know what's normal for their baby and speaking up. And I'll tell you why. And I'm going to, paraphrase what this research says in my layman terms, but the research is on our website if you want to check it out. But basically what it says is, when we get so focused on that hour range or the 2-hour range, that's what we focus on as humans. Like, I know I have an hour for this presentation. That's what I'm focused on. And I know I have to pick up my kids at 4. That's what I'm focused on, that hour. So when you tell somebody 10 and 2 or 10 and 1, I hear a lot. What happens is, let's say that individual has been counting for the last 2 weeks. They've been counting consistently. They know their baby's pattern. They know their baby's trend. It's 10 movements in 15 minutes. Then one day they're counting and they get 10 movements in 1 hour and 47 minutes. And they think to themselves, that's okay, because I know I should get 10 kicks in 2 hours. But for the last 2 weeks, I've been getting 10 kicks in 15 minutes. So really, I shouldn't follow that 10 and 2. I should follow what my baby's pattern has been for the last 2 weeks. So I should contact my provider. So we really want to stress, we want you to get to know what's normal for your baby. And we do not want you to compare to past pregnancies or your friends. It's all about that baby and that pregnancy. Another common one is, I can just use a Doppler device to monitor my baby's well-being. I think we heard this a lot more during the height of COVID. I think there's apps out there that you can get, and you can, I think, easily purchase the Doppler device, maybe on Amazon, but unless you're medically trained, we do not want you using a Doppler device to check on the well-being of your baby. It's really easy to think you found the heart rate, and it's your own heart rate. We also know that heart rate is one of the last things to change when baby's in distress. So whereas a change of movement is one of the first signs and warning signs that baby's in distress. So we don't want people to use a Doppler device, even when you go in to a clinic or triage with a reduction in fetal movement. They don't just do a Doppler device and send you on your way. They're doing additional testing. At least I hope so. If baby's not moving, I should drink something cold or eat something sugary. Again, this is very similar to the 10 and 2. Those are probably my top 2 most asked questions. But again, what research shows is that fetal movement monitoring is best done without interventions like sugary drinks or jumping jacks, I've heard. Because why are we trying to force the baby to move if they're not moving like normal? It's just like when you and I are sick, we're not chugging Gatorade or Mountain Dew, we're chugging Gatorade. We're not chugging Mountain Dew or eating a Snickers bar to get up and moving. We're conserving our energy, we're resting. Same with baby in utero. Something's going on with baby in utero that's making them not move like normal, whether it's infection, low amniotic fluid, umbilical cord issues, their movements are changing. Babies kick less near the end of pregnancy, adult wives' tale. I remember my grandma saying, "Oh, you look like you're about to pop, but I bet you can't. There's no space in there. Baby's running out of room." And I had like 4 months left. So anyways, babies move up to and during birth. We know this. You should still be counting. You should still be getting the same amount of movements in the same amount of time, whether you're counting at 32 weeks or 40 weeks. And then triage doesn't need Count the Kicks education. I don't know if I have any labor and delivery nurses up here or triage nurses on the call today, or hospitals or birthing centers. Absolutely, you need this information. We have a gold standard after visit summary form. I went to triage 3 times with my daughter. If you remember earlier, I had said she took around 20, 25, 30 minutes, and I was comparing her to my son, and I didn't know what was her normal. And so I said, how amazing would it have been to go into triage those 3 times for somebody to say, "Hey, let's talk about counting your baby's movements and getting to know what's normal." And then you can download this triage gold standard that we have and talk about Count the Kicks. But just because you go into triage doesn't mean you automatically deliver a baby. So why not have this information there? It's a perfect opportunity. Let's connect the dots for you, depending on whether you're birthing center, an FQHC, a dentist, a hygienist, whatever you do, you can talk about this. You can order the materials. Ensure everybody in your office knows about this. I can't tell you how amazing it is to have these types of presentations and these conversations and hear, yeah, I just keep them in my car and I drive around because I have a coalition meeting and I drop them off at the library. I'm in Iowa. I need you. We need you to help change the trajectory of the stillbirth rate. We cannot do it alone. So how can you include Count the Kicks paperwork, into your paperwork? Do you have an intake form? Can you ask a question after you ask the pregnant question? I think back to dentists. My dentist was the second person that found out I was pregnant with my second pregnancy, because I took a test the night before. The second day I had a dentist appointment and they had asked me all the has anything changed? Are you pregnant? Are you breastfeeding? And I said, actually, outside of my husband, you're the first other person to know. Not even my family does, because I just took a pregnancy test. Add another question there. Okay, you're pregnant. Which trimester are you in? And then, there's lots of different ways. I'm really passionate about systems change. If you can't tell, I would love to talk to you all individually. Contact me and let me know what you do, and we can talk about how to integrate this. That's what I'm here for. Discuss at every parent meeting, every patient meeting. You're going to have this. Can you have some of our videos, our baby safe stories, or our app videos in your waiting room, and then sharing throughout the community? Again, you are the boots on the ground. Some other resources, like I talked about, that CE training you can take, ordering the materials, and then our awesome, cool, innovative partnership with Dr. Johnson and his team with the Oral Health Office. If you didn't notice, because maybe you weren't multitasking yet, but if you go to counttthekicks.org and you click on order materials, click on Alabama, and you'll see all of our materials, but you'll also see this oral health bundle, and there's limited supply right now. But what that is, it's our poster that we have, but she's holding a toothbrush, and it talks about how oral health care, good oral health care, and fetal movement monitoring go hand in hand. And then there's also these magnets that go with it that are frames. So you pop out the middle information section, and then it turns into a frame. So it's like you could put an appointment reminder card or your ultrasound photo. What a cool way to be innovative and have dentists, hygienists, dental assistants talking about stillbirth prevention during an oral health check. I mean, that is just truly remarkable and amazing. And last November, I came to your great state. I got to meet Samille in person. I've known Samille for a couple of years, but I hadn't met her in person. I met Dr. Johnson in person, and Dr. Johnson and the team set up an amazing proclamation signing with your governor to make December Count the Kicks month. And focused on oral health. So it was truly amazing. The first state to do that with the proclamation signing, I can tell you, Iowa, our oral health group here was just like, we got to do that. We got to do what Alabama's doing. Like, how amazing is that? So we're really excited about this partnership. It has gotten national attention. I've spoke about it at an oral health conference before, and we're now implementing this project in several other states because of the success there in Alabama with it. So it's really exciting to see. And then you have amazing ambassadors there. You have two amazing individuals. Our ambassadors are volunteers. They're individuals that come to us, either they're birth workers or lost parents or baby safe parents. In Alabama, you have two amazing birth workers there that are passionate about Count the Kicks and stillbirth prevention and sharing this education. So if you ever need somebody in person, as much as I'd love to hop on a plane and come again, they can go to your in-person events. And a lot of them, Tiffany and Jasmine, they have been to several of your in-person events. So truly amazing individuals. And then I always like to end on one of our baby safe stories. So this is baby Nala, and this is her story.
She came back in after she had me put on the monitor and stuff, and she's like, we're just gonna take her. And I'm like, what? And she's like, you know, her heart rate is dropping every time you have a contraction. I was already scared, you know, because I was a high-risk pregnancy. Well, I basically learned from the doctor's office, the little yellow sign that was right there. Once she started moving, I was very alert with her movements, you know. That was what I lived for, just because I wanted her to, you know, her to make it and survive. When she started moving, she moved, and she was consistent. It was always at a certain time. Nala was a kicker. When she started kicking, she was kicking. And this day, she wasn't moving at all. I started drinking cold water. I mean, I was drinking so much, my stomach was hurting to make her move. And she didn't move at all for me at all that time. So I'm just like, okay, I'm gonna get her checked out. It was the heart rate that was dropping. Like they said, her heart rate would drop real low every time I would have a contraction, and they were like back to back. She thought that it would save the baby, so she pulled her out. She was like, it's a good thing you came when you did, you know what I'm saying? Because if you wouldn't have, you know, we probably wouldn't be having the same outcome. I think about it every day, like, oh man, what if, you know, what if? Definitely to pay attention and count the kicks, you know. I feel like it's important just because had I not, you know, knew to do that, Nala wouldn't be here. Don't second guess yourself. Don't feel bad or stupid. Don't worry about insurance or the emergency room bill. Go check on your baby, you know, because your baby might not be here. You just pay attention, you know, seriously. Like, it's your baby's life.
Like what Candace says at the end there, where she says, don't worry about this. Don't feel bad or stupid. Go check on your baby. It's your baby's life. I mean, can we empower our parents to ask those questions and feel comfortable? And it goes for providers too. Empower your patients to say, I want to hear from you. Hospitals are open 24/7. Like, that is my job. I want to hear from you. If you have questions or concerns, come in, call me. Make sure your patient, your parent knows which number to call, which hospital to go to. Make sure they have all of that. Let's work together to save these babies. You can follow us on social media, sign up for our newsletter. You can reshare any of our messaging. Go to countthekicks.org, learn more. I'm happy to answer any questions. I'm just so grateful for this opportunity and this space. I know it's a heavy topic, and I know that it's a heavy day, but I'm just so thankful for you all, because truly it is why we're going to save babies in your state. Is I'm just telling you this. You're the one that's going to do it. So I'll answer any questions you may have if there's time. Otherwise, Samille knows how to get a hold of me too. So thank you for this time. And then my references are at the end, but I'll have all of this.
Yes, we do have time. Everyone enjoyed your presentation. They're still clapping and sending you hearts, and they love that video also. So let me go to our chat box, our Q&A box here. So let me first say that we have many organizations in our state. It's not just ADPH, but I just, you know, that are promoting Count the Kicks, but I do, want to share who I know has this program, who has shared with me since then, who was promoting this program. So My Care Central promotes Count the Kicks. The All Baby staff here is promoting the program. They have the English and the Spanish. Gift of Life Foundation, of course, is promoting this program. Okay, so questions. How often should we recommend pregnant moms to count their baby's kicks to fully learn their normal kicking pattern when they first get the app?
They really just need to count once a day. So after a couple sessions, so probably 3 to 4 days, they'll start to see that graph change. So they'll see it right away. So I would say just go ahead and pick a time when baby's most active and start tonight or start today and then do it the next day around the same time. And you'll start to see your baby's pattern right away. I think sometimes we get asked, or told like, oh, I just need to count because I didn't feel movement for a while, so then I'm going to count. Nope, we want you to start right away. Like we want you to start right at the beginning of the 3rd trimester every single day. And after 3 to 4 days, you're going to start to notice that pattern or trend very easily.
Okay, would you say it's normal for a change in the quality or type of movements as pregnancy progresses, even if the number or frequency doesn't change?
Yeah, that's a good question. And so that kind of goes back to one of the misconceptions of, babies don't move. So what happens, and this is what I would tell, I'm not a medical provider, so maybe some of the OBs could chime in, but what happens is a lot of times when you get further along in pregnancy, instead of those like big body rolls, that you would have, you'd feel more of those like jabs, those types of movements. You should still be getting 10 movements around the same frequency and strength, but the type of movement is probably going to be more of those like jabs to the bladder and the ribs versus a full body roll consistently. So that's what I would say, but I'd love for a doctor to chime in too. But that's what research has shown too.
Okay, we have a comment from a user of the Count the Kicks app. She says that this app helped me when I was pregnant with my youngest, and we found out that he was IUGR. You know what that means? Okay.
Yeah, and
having
growth restriction. Mm-hmm.
Okay, I did not know. And having arrhythmias in utero and had to be delivered at 36 weeks. He is now a happy and healthy 2-year-old. Very grateful to my OB for recommending the app and making sure I was being consistent with counting his kicks. Right? We love that story. Thank you for sharing.
Story. Well, that person's anonymous, but if they'd like to contact us, we would love to learn more and share that story because we know that mom-to-mom storytelling, that parent-to-parent storytelling is really important. I just got goosebumps. I hope you all got goosebumps too.
Yeah.
So, yeah.
Can you repeat the Save Baby CE?
Yes, I can put it in the chat. It's just Save Babies -AL, and you'll have to do it in registration. There'll be a place for like a coupon code. Do Save Babies -AL, and Samille, I just sent it in the chat. You can copy and paste it over. If you're still having issues, contact me, but it should work.
There you go, everyone. Okay, and Megan's email is also in the chat box. I had a question about that. Are there any more questions? Okay. Well, thank you so much. We enjoyed this as usual. Thank you for the partnership.
Thank you, Samille. Good to see you again.
You too. They're still sending hearts and hand claps. And I hope everyone knew that this program was available and that it was free. If not, please let us know. We've been working to try to promote the program with everyone that we can. We've had Megan and other staff of Healthy Birthday Inc. Join some of our perinatal meetings, the like statewide meetings and the governor's initiative meetings. So we've been trying to spread the word, but we know there's still more to be done. So thank you all.
We've had over almost 40 orders, I think, in just the span of about 5 minutes. So y'all are listening and multitasking. I love it.
Okay.
So, all right. Enjoy your day. I'm excited for the next presentation. Thank you.
Thank you. Okay. We are moving on to our final presenter of the day. Dr. Derek Griffith is the founding co-director of the Racial Justice Institute. He is the founder and director of the Center for Men's Health Equity and a member of the Lombardi Comprehensive Cancer Center and a professor of health management, policy, and oncology. He's trained in psychology and public health, and his program of research focuses on developing strategies to achieve racial, ethnic, and gender equity in health. So let's welcome Dr. Griffith. Thank you for joining us. Let me get you set up here. Okay.
Very good.
Yes.
All right.
Everyone can see him in his slides, correct? Yes, hand claps. They can see you.
Okay,
Thank you, sir.
wonderful. All right. Well, thank you. Good afternoon, all, and thank you for this invitation. I look forward to this opportunity to share with you and to learn from you in the Q&A. Today, my talk is, I was asked to talk about the role of fathers in fatherhood and those perspectives, and I'm going to talk about a particular project and some of the lessons that we've learned from speaking with fathers and doing focus groups with fathers around these particular issues. The title, as you can see, is really about amplifying fathers' perspectives, needs, and recommendations to facilitate maternal involvement during pregnancy and childbirth. And chose that title because it's really about, again, taking the information from fathers and learning from them what are the things that they need, and then having that be the foundation for how we try to change policy and practice in the work that we do. Let me begin by just saying thank you to, again, in addition to the organizers for inviting me to join you, to the men who participated in the focus groups, to all the site staff who helped to organize the focus groups and to do the member checking feedback. So we actually had site staff who we presented some preliminary themes at a meeting that we had in New Orleans to make sure that we were understanding the findings correctly, and that they provided some feedback to help shape and frame and give context to some of the things we're finding. So we're relatively confident that what we're presenting is reflective of their experience, their expertise, and the men themselves. Let me also just say thank you to my colleagues at the National Healthy Start Association. They're the main ones who really brought me into this work to work alongside them. Deborah Frazier, Karen Chutz, and Amber Wilson are the main ones. They have a larger team clearly, but these are the main three that I've been working with at the National Healthy Start Association. And the main project that I'm going to talk about, AIM CCI, or build from, AIM CCI is really their project, and they brought me in to help with the qualitative work and the men's work, the fatherhood work as well. We also say a quick thank you to my team and the Center for Men's Health Equity, the Anchoring Sort of research team that helped to conduct the focus groups and do the analysis and some of the papers, and the grant that the National Healthy Start Association got from HRSA. Okay. So my goal today is really to talk about four things. I'm going to start with just talking initially about how fathers and other men think about health, to talk about the media and professional narratives regarding fathers' involvement in pregnancy and childbirth, then talk about AIM CCI, which, as you can see, because I would not remember this by itself, the Alliance for Innovation on Maternal Health and Community Care Initiative that is funded by HRSA, and the findings, again, from the focus groups with fathers, and then an overview of some of the implications, some of what men said about what are the kinds of things that we should do as a result of what we've learned and how we might approach that. So to start with the conversation about how men think about health, I'm going to start with a story that is often familiar to folks there, but in some cases may not be, this idea of, in the story and the fable of John Henry. And John Henry was known as the steel driving man. He was known for, again, this fable was during the time, or was set during the time when they were trying to, the Industrial Revolution, you had the period when we were trying to build railroads and other things to advance our ability to produce and distribute things. And his job was to bore holes in mountains to put explosives to then be able to blow holes through the mountains to then create paths for trains to go through. And he was known as one of the strongest men, certainly in his job and his role, was known particularly for his skill in his particular role, and was particularly successful at that. some of the characteristics associated with John Henry and John Henryism, if you think about this as more of a larger sort of analogy, that he was considered very hardworking, tenacious, very ambitious, optimistic, and persistent at what he was trying to do and trying to lift others along with himself. And so even in some versions of the story, his wife and child were on the tracks watching this man versus machine race of him trying to bore the hole through the mountain, as well as a steam engine trying to also bore the hole through the mountain, and so forth. As you all know, or for those of you who know the story, in this man versus machine race, he actually won. But that is not the end of the story, and that's not the point that I'm trying to make here. He won, but then he dies on the tracks. And so depending on where you stop the story, it is important to recognize that the reason in the application to this, and what we're trying to do here, is to connect the dots of, yes, he was successful in his chosen profession. He was actually quite exceptional in his chosen profession, but it had implications for his health and well-being. He decided, this strategy of, I'm just going to put my head down and continue to work as hard as possible without really taking care of himself, without taking care of the way that he was managing his own health and well-being or paying attention to his body, and necessarily even just looking at the roles and responsibilities that he had and balancing his role as a father and his role as a employee or a provider in that family context. He was successful at his job, but it cost him his life. And so it's this idea of, as we sort of translate this fable to today, that he ended up focusing much more on his professional success than his own health. And so we remember him positively. Part of this is the paradox, as we talked about it in other spaces, that on the one hand, we remember him generally positively, excuse me, for being this very successful man in his particular chosen profession, having these attributes and characteristics that we admire greatly, but that also we tend to forget that there is a cost to that. And we tend not to recognize that as we sort of bring this story forward to today. This is a story that we wrote for a news outlet called The Conversation, and then other major media outlets, and particularly newsprint, can pick these stories up. And it got picked up well over 100,000 times globally in 2019, and then they actually posted it and republished it this year, and it got a decent amount of attention, really nothing like it did initially. But the point was this idea of fulfilling these roles in families, in the roles of families, the roles in communities and so forth, was something that these men were doing and doing well, but they often weren't paying attention to themselves and taking care of their own health while they were doing this other work. And it's important to strike the balance between the professional roles and the way that they're trying to take care of their families, themselves, and do those kinds of things, but also how do they take care of themselves? Again, my job here is to focus on fathers. Clearly, this is a very normal story for mothers. Mothers do this probably even more so than fathers in many cases. We always talk in the work that I do, we talk about women having that second shift when you come home, you've worked a full day, and then you're supposed to come home and basically take care of family, children, and so forth in that whole context. And so this is not to say that this is a gendered story in the sense that it doesn't affect people of other genders, and certainly not women. It is to say that we need to better understand how men are prioritizing thinking about these issues. The way that they're valued as men often is seen for them and through us for how we are able to fulfill these particular roles and responsibilities, regardless of the cost that it has for our individual health. We know that we're supposed to prioritize health, but we also know that often health is a priority that comes after we've actually put other things ahead of that. And taking care of children, earning an adequate income, contributing financially to a household, are all these things that are basic to what we tend to prioritize more than our individual health, and frame that as part of the way that we understand what these issues are. Just keep things a little better. This is a quote from a focus group that we did some years ago, where it's basically sort of reiterating the same point. And it really, often health is what we call in a more technical language, an instrumental value. It's something we don't really tend to pay attention to. We don't really often tend to even care about our individual health unless it gets in the way of your ability to do something else. So it's something that we treat our bodies often as tools that we don't really need to worry about, but we only worry about if it starts to break down. And part of this in the men's health context, in the context of even fathers and fatherhood, is we need them to also try to strike a better balance and have more of a both and between taking care of their health and taking care of these other roles and responsibilities. And how they think about that has to change as early as they are becoming aware that they're pregnant. And so this is one of my favorite images. This is actually a real campaign that the Agency for Healthcare Research and Quality had several years ago to try to frame messages and to try to help men get the preventative health care that they needed and to go get tests and so forth, because we know that the gap really between men and women in healthcare seeking is really in prevention. It's not when you're symptomatic. Even though we tend to think about, men don't go to the doctor and all those kinds of things, the real difference between men and women in terms of healthcare utilization is really in preventive healthcare when you're well-person visits. It's not when you're actually ill. Women don't go to the doctor as much as they should either when they're actually symptomatic or having problems. It's just that they do better than men, which is a pretty low bar, as much as I hate to say that. When I transitioned to this idea of thinking about narratives, yeah, I had to take y'all back. So I'm a child of the 70s, and I grew up on Good Times, Jeffersons, and other shows like that. And I start here because one of the things that we had in that context was, despite all the challenges, the economic challenges that the Evans family, James Evans Jr. and Sr. had in their lives in context, we had this idea of a strong family and a strong father figure being sort of the anchor and the foundation of that family. One of the things that was important, that wasn't accidental, and that wasn't something that went without activism, action, and deliberate intention, not just by the writers of the show, but actually by Esther Roll and others. But she in particular was making sure, and in her, just because of her status, her power as an actor, and just the role that she was playing in the context of the larger sort of community of folks in that space, she would make sure that they did not tell or perpetuate this idea that Black fathers don't care about their children, that it was something that she was very adamant and active in making sure that behind the scenes that show did not produce and reproduce these negative images about Black fathers, when it was quite common and really more culturally normative to see Black fathers in a negative light. And so we have to continue that. Now, I leave this in here because with all the craziness that Will Smith has gotten into and the way that we think about him now, God bless him and his family, but before he lost his mind a little bit on that stage, that fateful stage, there's been a lot of attention to his role as a father, the way that he embraces his children, the way that he plays a positive role in the lives of his children. And so this was just a quote that I found that I thought was really powerful, that really highlights that when you have these ideas of men being fathers and these ideas of how they want to be remembered, how they want to be connected to their children in those lives and so forth, that it really does start from both this overwhelming sense of excitement, enthusiasm, but also fear that can I live up to what is required for me to fulfill this role and responsibility? And they feel the awesomeness of that responsibility and opportunity and are trying to live up to that. So it is in that context that you have these dual pieces of trying to understand these pieces that we sort of enter this conversation about fathers' roles during pregnancy. And this is just, I'm going to highlight a couple things, but we're going to use the themes from an article that I wasn't part of to talk about some of the work that we did. But one of the things that has been sort of contentious, again, in this larger narrative that fathers, particularly Black fathers, may not be as active as we would like during pregnancy and certainly during the first years of life that we're going to focus on during pregnancy, but that we have these narratives that fathers aren't as active and connected. And so how do we actually think about what those issues are? And so they tried to, in this particular study, Elio and colleagues basically tried to interview fathers, do focus groups with fathers to better understand what kinds of roles and how to think about the role of fathers in early in pregnancy. And so it is using that framework that we did the focus groups for the AIM-CCI project. Again, the Alliance for Innovation on Maternal Health Community Care Initiative that was funded by HRSA to basically inform the development of non-hospital bundles to improve maternal health outcomes and so forth. One of the things that was novel about what we are trying to do now is to figure out what are the ways that we need to engage, involve, and support fathers in that process. How do we actually make sure that fathers are getting information that they need to be the most supportive of mothers and expectant birthing persons during those time periods? And how do we actually support and provide them the information they need? And so getting information from them to guide that is part of what this task was. And so we wanted to, through the focus groups and through having these small groups of men sort of in this semi-structured discussion, examine what are these social, cultural, and other factors that influence their choices, the way that they think about fatherhood and so forth. We wanted to also explore some of the things that they talked about when they were seeking care. Were they seen and visible, or were they sort of treated as though they were invisible and ignored when they went into the visits with the mother or with the expectant person? Were they thinking about, how were they treated during and following up in sort of childcare visits and other settings and so forth? We wanted to really center their experiences to really inform how we would think about these bundles and the information and the programs that we would include in federally qualified health centers and other things as this program tends to roll out. And so the AIM-CCI is, we're in the pilot phase of it now. There's 6 sites in the country, and I'll show you the 6 sites in just a minute. The methods for doing the focus groups were, again, as I mentioned in the thank yous initially, the site staff who were the ones who did the work with expectant mothers and with the fathers and the fatherhood programs, if they had them at the staff, where they were the ones who did the recruitment, the engagement with the fathers. And so we really relied on them to do that recruitment. This was during the height of COVID. So all of these focus groups were virtual. And the fathers were eligible if they were 18 and older and had a child born within the last 2 years. They didn't have to be connected to the services that are being provided by the federally qualified health centers that were the host sites for this pilot program, but they could be, and they were more than likely sort of connected to them. And they had a broad sort of breadth of virtual ways of expanding the ways that they sort of connected and recruited across these different groups. And so this is the kind of, we did the qualitative analysis, really looked for themes of how to do that. Phenomenological thematic analysis just basically is a fancy way of saying that we looked for how the people explain and utilize the terms in the way that they talked about these things, as opposed to me imposing from my lens what the way to think about these issues. And so we wanted to use their language as much as possible to create the themes and create the narratives and better understand what those issues were to do that. And so there were 5 groups. We did, again, there are 6 sites. Grand Rapids, Michigan is the 6th site that we did the focus groups, so that there were questions from the site staff about whether or not the participants that were recruited through them actually did reflect their community and context. So we elected with them not to include their data, the focus groups that we did with the participants that were from Grand Rapids in these particular analyses, but we do have that information and are still working with Grand Rapids, of course, to do this work. But Atlanta, Fresno, New Orleans, Tulsa, and Newark, New Jersey. So quite a range of places across the country. 2 focus groups in each place. We had, as you see, between 10 and 20 participants per site. The reason I'm framing this mostly as African-American men, or highlighting that, is because 86% of the participants were African American men. And, just that there are a lot of things that sort of fit that larger narrative. Most of these things and all of these things, so as far as we can tell, did apply to other groups. And even the framing and the initial work that I did and talked about the ways that men think about health, while that came largely from work I did with African American men, we've also repeated that work with Latino men and found similar patterns, very similar sort of ways of thinking and approaching. And anecdotally, when I've presented this work, actually in Alabama and other places before, regardless of race and ethnicity, men have seen, or people who are connected to men have seen a lot of similarity in the themes and approaches of thinking about how men think about health, what that means, and how they think about their roles and responsibilities relative to some of these other issues. So the key themes that we want to touch on today are really, I wanted to start from the positive place, again, given the Will Smith quote and just some of the other things. What does it mean to be a father, and how important is that? Is this something that, again, that given the narratives around, do fathers even care? Are they even trying to be fathers? What does that actually mean? That the importance and meaning of a father, of what it means to become a father, that was something we wanted to see, was that important to them? What does that mean to them, and so forth? That we also, the other three themes are really coming from that paper that I mentioned before: accessibility, engagement, and responsibility during pregnancy and childbirth. And we're going to walk through what each of those pieces were. The importance and meaning of fatherhood, again, we started there with this question because, again, most of these things are really looking for deficits. And we really wanted to recognize and start with this idea of strengths. And again, pulling on all the comedy and all the drama that there was in Good Times, that there was also this importance of James Evans Sr. being a good father. And it was very clear that he was the rock of the family. Well, you can debate about whether or not he or his wife, Florida, were the rock, but certainly they were co-rocks, if we will. But certainly they were very instrumental foundations of that family and of that unit. And both of them had these very positive images of the importance of their family and what the importance of that role, and they took those very seriously. And so we found that fathers, started this process when they learned they were going to become fathers with this level of excitement and passion that's really hard to even characterize. It really gave them a sense of purpose, a sense of mission. They talked about this being something that was so important and life-changing for them, because it changes who you are. Your role, your identity changes because you're becoming a father. It becomes now a core part of who you are as a person. Like, that is one of the fundamental roles that men now have, and you have that as part of your identity, much like being a son, being a nephew, and whatever these other roles, contributing financially to a household or providing. That all of those things are ways of thinking about roles and identities, but this idea of being a father was also very instrumental to how they saw themselves. Having said that, similar to the initial quotes, and particularly the Will Smith one, that the concerns and fears about that, yes, they were hopeful and positive and inspired by this and wanting to look forward to it, but then they were also realized that it was a scary and daunting opportunity that they were facing, and that they were looking forward to it, but also worried about, could they live up to the expectations and roles that they know that were coming. And so this accessibility is the first part of, the idea of, are you actually just available? For fathers or expectant fathers, were they available to the mother? Were they available to her while she's pregnant, or the expectant person? They had to really learn how to shift their focus from being very independent to thinking about, okay, how do I need to pay attention to her? How do I need to recognize that this is not just about me, even before the child comes? And so one of the things, fast forwarding to some of the recommendations, is this is not going to be unfamiliar to this audience, but to start thinking about fathering and fatherhood from conception, or certainly from the time that the couple knows that they are having a child, that we need to start thinking about the role of fathers and preparing fathers from that point not waiting until the child is born to start to prepare them for doing those things, and to create services, to create sort of those conversations and opportunities for them to learn about those things and to prepare them for the life changes that are coming. That they really needed to be, again, not just sort of, that they had to sort of be available. They had to be there just for her, just be present, regardless of the situation, the relationship, the nature of the relationship. But they, say it takes two to tango, or however you want to frame it, but that they needed to be there, and that they're pregnant. It's a unit that is pregnant, not just her. And so they had to be part of that person who is responsible for making sure that she is well, that the baby is well, and that they needed to be part of that process. So even with the kids, the previous presentation talking about the kicking and so forth, like those kinds of things he needs to be involved in if at all possible, so he can start to get a feel and connection, because we know that it can be harder for fathers to get a connection to the baby while the baby is in utero. Accessibility is not just that you're present, but that you're actually making sure that you're engaged in that process, that you're giving time to family, you're creating time, that regardless of your work schedule, that they needed to make sure that they were available to figure out how they were going to adjust so that they could take care of some of the household responsibilities, other children in the family unit, in the family context, or again, regardless of the nature of the relationship. If there were other children involved, they needed to be part of that process to take care of that. Cooking, and those kinds of things. And many of them talked about that they had stepped up and taken on more of those roles that were not traditionally the things that they had been, actively part of, but were nonetheless important for them to be part of that process and to create that bond, again, with the mother, and with the child, while in gestation and going forward. And that one of the things that we also were particularly interested in terms of accessibility and were they available, again, given during the COVID period, we're concerned about, were the COVID restrictions something that were hindering the ability of fathers to be part of, the visits, the doctor visits, during pregnancy and so forth. And, there were sometimes tensions that the fathers would face, the expected fathers would face, in terms of who could be in the delivery room, sometimes who could be during the visits, and whether or not that person, whether it was the mother or whether it was someone else. And they didn't have any necessarily individual rights to be there. It was, of course, as you know, well, up to the mother who could be in the room with her when she is delivering. But nonetheless, some of the fathers really wanted to be there, and that wasn't up to them and their choice. And so there were these tensions of, I want to be there, I want to cut the cord, I want to be part of this from the very inception, from the first time that my child opens their eyes. I want to see, I want to be one of the first people he sees. In this case, is the quote. That making sure that those things were part of the process, and that again speaks to this larger commitment and interest and desire to be part of this process and to be a good father, that was something that again very much counters this larger narrative, and very much fits with the ways that they talk about these issues. That some of the challenges with transportation and other kinds of things, that the conflicts between job roles, these kinds of transitions and so forth, that they had to navigate a lot of these issues, but they needed to figure out, and they started to figure out how they could make sure that they were facilitating and helping the expectant mother to be active and to do the kinds of visits and so forth, and make sure that she was taking care of herself, that she was eating, that she was, still being active and so forth, and watching and making sure that she was actually aware of the kinds of things, and he was being attentive to her health and well-being as well. The engagement is the third area, specifically, that we wanted to sort of touch on and explore. Again, it's consistent with the prior themes. That it was really about how it's not just being available and accessible, but it's actually how much are you, stepping in 10 toes down, like all in with the conversation and with the work. and to be active during that pregnancy process. And a lot of them, of course, we heard more from the folks who were doing it, who were seeing themselves as being a positive influence in this. Of course, this is some of the bias that comes with doing qualitative work. And we did have some range in sort of what fathers were doing or not doing in terms of being engaged and so forth. But a lot of them did talk about that to not make the assumption that they were not involved, to not make the assumption they were not interested, and that many of them were trying to be very active and trying to facilitate roles where they could be part of that process, and they just wanted to know how, where, and what roles they could play. And so, they would try to make time as best they could. They would try to engage with the provider, ask their own questions to take in as a way to better understand what was going on with the mother, what was going on with the baby as the baby is growing and developing, but how they understood those things. And they would have their own questions, interests. Some of them would have their own virtual diaries of different things and have their own sort of concerns. Well, she's doing this and she wasn't doing that. And how do I get these kinds of things to change and so forth. So all of these things are fundamental to the ways that fathers were trying to be involved, or expectant fathers were trying to be involved during that process. There were some missed opportunities that a lot of them felt like there weren't enough information for what are the ways that they could be involved, or what is the information that that they needed to be the best facilitator, the best in being part of that role of being engaged and active as part of the life of the expectant and new mother. But how to do that most of the information, they felt like they were kind of looking over the shoulder of the expectant woman and to try to get information. They had some little pamphlets and so forth, but there was not a lot of information that was necessarily directed at the fathers themselves. And so they saw that as a missed opportunity to really connect with them and to give them the information they needed to be good fathers during that process. Part of it was also that they saw going back to sort of the John Henry sort of thing, and this idea of, balancing roles and responsibilities, that they did sort of lean into some of these masculine sort of ideas of being part of their responsibility as men and as fathers were to make sure that the baby and the mother were safe, healthy, and that those they prioritized making sure that those roles of making sure that they were taken care of and facilitating and helping to make sure that not just the child was safe and healthy, but of course the mother was as well, as best they could. And that clearly the financial responsibility was something that they were most concerned about, and that they were often very much hyper-focused on their concerns about whether or not they could actually be financially responsible and contribute financially to making sure that they took care of the child, much less to make sure that they helped to take care of the mother and, while she was pregnant and so forth. And so contributing to that was a really important part of who they were and how they were thinking about it. The resources that they used to answer these questions, what was important to understand is what resources did they use to make some of these changes. If they didn't know what to do, where did they go for that information? So clearly the most obvious thing is if they had their own medical provider or would go to the visits with the expectant mother, they would ask the healthcare provider or still maintain a relationship with them or call the nurses at the OB's office and so forth, and try to ask their own questions if they had questions or concerns and so forth. Obviously, mothers were a huge role for the expectant fathers, both in terms of trying to understand what was going on with the mother, the expectant mother, what was going on with the pregnant person, what was going on with the changes, the gestation, and so forth. So they would often, mom was an essential part of these men's lives. And when they were trying to figure out a lot of the challenges with even trying to deal with some of the relationship challenges, they would often consult their mothers and so forth. And so just moms were a really essential foundation for that, and how to understand what the expectant mother was going through. Men often looked to their moms to help provide guidance to them, despite these being adult men. Third, often, for the programs that had it, Healthy Start, they would have text messages. They would have certain programs that places did have some programming and information, some information specifically for fathers and fatherhood training programs and so forth. And when those were available, they did tend to, for those who participated, they found them very useful. I think just anecdotally, we didn't actually interview the staff, but again, in doing the member checking, the follow-up sort of focus groups with the staff, they did say that those tend to be underutilized. And so we need to find better ways to make sure that fathers know that these resources are available to them. And so to make sure that they actually utilize those things that are available so that they will stay available as well. So where did they go for help? Just sort of elaborating on that a bit more. When they were talking about sort of their needs, the mother's needs and so forth, they went to for family and friends when they needed sort of moral support, information, general questions and so forth. When it was questions about sort of, again, having to navigate relationships, those kinds of things, they would often go to mothers and friends with medical backgrounds. Dr. Google, of course, got a lot of attention, and they would tend to search, just anything and whatever sort of popped up. One of the things that we wanted to think about was whether or not did they have any criteria for looking at the information and the sources of the information where they were getting things. And they didn't necessarily, and we saw that as one of the things that could be one way that we could help to refine the resources that we provide, is to make sure that they knew that as much information they can find on the internet. There also a lot of misinformation, inaccurate information, and so as much as they were not necessarily attuned to which sites and how they would sort of look at it, that we needed to make sure that they were aware that here are some sites where you can trust the information a bit more, where the information may be a bit more accurate, up to date, and so forth. And similar to the, again, previous presentation, address some of the misinformation that may be out there. When they had questions about the baby or infant development needs, again, healthcare professionals, some of the messages, if there were new fathers classes and so forth, that those were something that they went to. Financial planning needs and family planning, that there were, financial advice and counseling and therapy services. Again, healthcare professionals became a foundation for that. A lot of them did have concerns and experiences, connections to the legal system, whether it was their history of incarceration themselves or other things that they were concerned about. And so they needed to be able to seek out legal counseling and connection to deal with those things that would make their ability to be connected to the expectant mother and to the family unit, excuse me, and the birthing person, that those things would be important for them to connect with, and that addressing those legal needs was something that they saw as a really important issue that they needed to make sure that they dealt with as well. And then the stress of them becoming fathers, and the complications, the changes that were going on with the mother, their particular interest and investment and concerns about the health and well-being of the mother and expected mother. All of those things were genuinely things that they were worried about. And so they would often, again, go to healthcare professionals, to the internet, mental health resources when they were available, and just other people that they happened to know in their network of friends and peers that they had dealt with these things before. So whether it was family members or friends that had children and so forth, that's who they would sort of talk to. So one of the things that we asked also, again, to focus on, again, asking questions that allowed us to get information from fathers and recognize that they were also an asset and a source of strength, and not just, again, a context for, basically focusing on all the deficits and all the things that fathers don't do, and particularly all the narratives that Black fathers aren't interested in these things. We wanted to ask them, what are their recommendations for fathers to, what are their recommendations for health professionals? What are their recommendations for expectant and new mothers? What are their recommendations for the health system more generally? And so they talked about that, again, these narratives that I keep referring to, for them, it was really important that we start to really explicitly counter these narratives, that they heard that, they were seeing that, they were experiencing that. And so the reason I've made such a big deal about these narratives and brought in, dated myself with good times and so forth, is because this narrative that really perpetuated and infiltrated throughout all their experiences was something that they experienced, and they felt when they would engage with services that they really were treated as though they were going to be deadbeat dads, and so people wouldn't really engage with them in some ways that really felt like they were genuinely believing that they were trying to be good fathers and be active in the lives of the mother as well as the lives of the children. And so to really don't forget the fathers in that process, and don't go in with the assumption that they're really not going to be around, that they're not interested. They actually start with a very place of really being genuinely very invested in this. And it's through the experience that they actually start to pull away and be pushed away. But it's not just, the point is they start from a place where they're actually genuinely interested and invested and really trying to be part of this process. And it's through the wearing and tearing of that they actually start to be pushed away and pulled away. And so we want to think about, again, just as a big picture, just sort of as we sort of move to closing this out, men are willing to actually ask for help, as unusual as that sounds. We will actually ask for help. We will actually ask for support. It just has to be geared to us as men. And actually it has to fit and be something that it feels like was actually designed for men and that actually is involving men. That we want to think about how to actually, again, from a very positive perspective, and make the assumption that they're actually trying to be committed and involved in the lives of the mother and expected person and the child and so forth, that they are committed and invested in that, but they often don't have the adequate resources or support to be as active and involved as they would like to. And so this idea of being accessible, engaged, and responsible, we did find useful as a way to think about the ways that these fathers were trying to be involved and some of the challenges that they faced in that work and in those roles, and that we really wanted to make sure that we highlighted that they were actually trying to be accessible, trying to be engaged and active in those roles, and trying to be responsible. Again, this is not a universal thing. I can't say every father necessarily did this, but to start from the assumption that they do want to be involved in those things, that's an important place to start. From the point of policy and practice, that again, fathers really need support. They really need to design services and supports and resources that help fathers be more supportive to mothers, to help fathers be more supportive to women during pregnancy and so forth. That we need to really think about and expand this definition of fatherhood and provide services from the prenatal period, not just wait until they're in the delivery room and then we're like, okay, here's a brochure, go for it. That we really need to engage fathers as early as possible to monitor their mental health, because they are also struggling with oh crap, now I have to do this, and how am I going to do that? And it's not just about some of them, they are really anxious and concerned about those issues, and we really do have to take seriously their mental health, their concerns, and how they are potentially sometimes, when they're unavailable and inaccessible to the mother, to the expectant person, that it's because of their own mental health that is being just the amount of stress that they're under. We have to pay attention to that more seriously. That there are tools like the Father Advocacy Toolkit, the shameless plug from National Healthy Start Association, that these kind of resources do exist. I'm sure there are many other from some of the local agencies within Alabama that you can, again, disseminate amongst folks to be able to, don't have to reinvent the wheel, but utilize those resources, utilize this as an opportunity to share what are some best practices, what are some resources that you all can use and test across sites to see how useful are these things, and then to evaluate them and then to refine them as they go forward. Again, the financial stress of becoming a father was something that they immediately went to. When we talked about stressors, immediately it was about money. And while when we compare that to the ways that women talked about in previous other literature, and again, I look forward to correcting anything I'm saying in the question and answer, but their immediate focus was, how can I be a financial provider for these for my now family and for my child, and for contributing to making sure that I take care of this responsibility that I've helped to create. That stress, that was immediately where they went. It wasn't as focused on being active and involved and connected to the mother. They were like, I need to make more money. That was their immediate sort of thought and focus. And so again, going back to, if that's where they're focusing, they may not put as much attention into being actively involved and engaged with, how is she doing? How is her health? How is she transitioning? Is she, again, to monitoring the nutrition of the expectant mother, monitoring her health and well-being? Is she still being active and moving around, or is she sitting a lot? And so is that going to put her health and so forth in jeopardy, and of course the baby as well? So like recognizing that those kinds of things, the financial stress was really an anchor for them and a trigger for them in ways that I don't think we always fully appreciate. That's where their mind goes, and it doesn't go to, I need to be connected and actively spend time with my with the mother. They are like, okay, I need to make more money because this is expensive, and I need to really focus on that. So we have this disconnect that we really have to deal with, that we really need to pay attention to as well. Yeah, just to note, as a researcher, I have to always talk about limitations of what we did. We only did a couple of groups per site. There was no random sampling or anything. So I can't pretend like this is something that is universal, but it is something that we have to pay attention to. The internet, of course, the fact that we did this virtually and people had to have reliable internet and so forth, were things that we had to pay attention to, and that we're limiting the sample of who we could actually get to participate. Some people may not have said things because they were familiar with others in the group. We tried to monitor who dominated the conversation and so forth, but we weren't always perfect at doing that. I wasn't, because I was facilitating the groups. And to again, we used, most of the people had their cameras off when they were part of the group, and so we weren't able to utilize that kind of body language to for many people to see how they were engaging with the questions or how they were responding and so forth. For AIM-CCI, and just for this pilot program that is going to be presumably scaled up to and rolled out across the country in the next few years, that the need to integrate the father's perspectives and the need to integrate services for the fathers is where we are in the process now. That we needed to recognize that quality improvement goals serve as the foundations that we need to sort of make sure are the anchors of how we actually do the work and what we're actually looking for as metrics of success. And that those are the building blocks for how we need to sort of create resources for expectant and new fathers, and that those currently are lacking. We don't really have QI measures and metrics and services that are designed for fathers to really do that. We need to create mechanisms to get that information and to have this 360 communication pattern of getting information, support, and a sense of community and connection for fathers, and really recognize what are the things that they need in their lives to be successful and to be healthy and well, and how can they be most optimally involved and engaged with the family unit, with their loved ones, with, again, mothers, fathers, and so forth, who are providing support to them, siblings and whatnot. That incorporating resources for fathers, that again, we don't have a lot of those, particularly during the prenatal period, and to make that more of a standard of practice, and that make sure that just they feel important, relevant, and are not invisible in the larger process. So one of the reasons that Black fathers and fathers in general may not be present in certain spaces, though, is just to remember that sometimes they're too busy actually engaging with the kids that they have, trying to fulfill the roles and responsibilities they have. So maybe they're not participating in research, maybe they're not evident where they are because they're actually just too busy trying to do what we want them to do. So hopefully we'll think positively in that way. Thank you.
Okay, thank you, Dr. Griffith. They're sending you hearts and hand
I
claps.
see. Yes, thank you all
They
so much
thoroughly
for the
enjoyed that
yes,
presentation, as did I.
thank
Very
you.
informative. Were any of those photos from your participants? Were they all like, okay, just curious. Alrighty, let's go. Someone says thank you. There were some other 70s babies and fans in those television shows in there with you. They were sending their hearts for that too when you mentioned that.
Yes,
Miss
yeah.
Rose's comments, of course, I think they really connected with her comment and those pictures, particularly with that father and baby looking at each other, that eye contact. A lot of people like that.
Yeah.
Love what you were saying about the policy implications and that father inclusivity. And I was happy to see that a doctor was encouraging that dad. You know, we don't always see that. Just as you said, some people said that they were really kind of pushed out and there wasn't a lot. So I was surprised to hear that someone had that comment, that positive experience, but thankful for that. And just people just keep saying excellent presentation. Thank you for being with us. Great presentations. Thank you, thank you, thank you. Are there any questions from anyone?
Yeah, or comments, other
They're
comments.
just like, thank you. I think people are so happy to have someone speaking on behalf of the fathers and focusing on them and actually sharing some research that has been done with the fathers. So we appreciate that. Anyone else?
I have a question.
Okay.
Go
ahead, Jesse.
Dr. Griffin, quick
Yes, sir.
question. How do we go about changing the mindset of those who may not be used to including fathers in the birthing process? I know a lot of fathers I deal with, even their hospital experiences are different. So how do we go about helping the community change their mindset and include fathers in that process?
I think it starts with events like this and to have, you know, a broader range of folks, you know, speaking in unison that fathers are actually genuinely interested in this, and you are missing an opportunity if you're not seeing fathers as someone that it can be a resource to monitor the health of the mother, to help them be involved in those kind of things. They are there, they're present, and they, you know, whether they like it or not, are invested in this process and this process being successful. And so to help them sort of realize that this is an important person in this picture that they would benefit from engaging. I think some of it could also be, you know, depending on resources, you know, creating other ways of doing, you know, media campaigns or working with groups like, again, National Healthy Start Association or others, HRSA and so forth, to create, since they can create ones that pick on men and not going to the doctor, can they create ones that are actually going to help, you know, change or at least engage healthcare providers in thinking about the ways that they may approach or decide that they, you know, need to be you know, part of the process. So, you know, I don't know if it's a men are pregnant too kind of campaign, or that's a horrible probably way to think about it, but like, there's something in that context of, you know, making those things available that we need to pay attention to. So I think it is by starting with having the fathers demonstrate that they are genuinely interested, that they are invested, and let them be told no, let them be pushed out, as opposed to assuming that, and it does put the fathers in a more vulnerable place. So I understand that, and I don't want to make it sound like I'm not recognizing that that is difficult, to put yourself in that vulnerable place to then be ignored, dismissed, you know, not paid attention to. But I think it's by showing up and showing that, nah, I'm here for this is important to me, you know, and to be part of that process and to make sure that they're demonstrating, no, I'm serious about this is not who you thought I was, I'm who I am.
Okay, thank you. I have two more questions. How do you keep a father engaged throughout the pregnancy? Any tips or suggestions? Comments?
I think some of it is making sure that he understands what roles he can actually play. Like, what is there for him to do? Like, I think that is part of it. Like, how do we help them understand what can they do? What are the roles they can play and so forth? I think you all froze on my screen, so I'm not sure if I'm frozen on yours, but yeah, I think a lot of it is just finding what are the concrete basic things that they can do to be involved and how to make sure that they are aware of here are things that they may be able to do. Some of them may not be glamorous things, but you know, cooking for the expectant mother, making sure that they're taking care of other kids, all those non-glamorous things may be important things that we need to pay attention to just as basic things that would be helpful to get them involved in both the pregnancy as well as the health.
Okay, there was another question someone asked. How do is it a stigma that has been put out about African American men by society that makes it harder for them to break through some of those fatherhood myths?
I think absolutely, and I think the fathers spoke to that in some of the quotes, and that was kind of again why I presented that. Even the stuff from Good Times from 50 years ago, that we have seen this stigma, these expectation around Black fathers, the narratives around deadbeat dads and other things like that, that becomes part of how we assume that fathers are going to be, and as opposed to assuming the positive and then having, if that ends up being something, then okay, fine. But it is that stigma that has been something that they're facing. And so part of what pushes them away is the facing that stigma and feeling like they're being frustrated, ignored, treated with disrespect, and all of those kinds of things. That's what also is part of the process. So it becomes a self-fulfilling prophecy sometimes because they're feeling all that negative attention, if they're getting any attention in the process at all.
Right. Okay. Thank you, Mona.
We had two more in there. Someone, Erica asked, how can we stress the importance of male involvement with the mom of the baby? And Steve Garrett said, how do we help them understand that a father's role is more than just a financial obligation?
That is a great question. I think this would be where I would tag in my colleagues who are working more specifically and explicitly with women to answer those questions. This is where I would, I can't answer that part. I can say what I'm a little nervous about answering. I can tell you from my opinion, but I'd rather not. But I think it is some of it to show that there can be useful things that they can do. And even just the framework of the accessibility and those kind of things, that he is something that can be useful. And to highlight that, he can play a role, and then thinking about what are the ways that he can be helpful to you, and seeing if that is something that is possible given the context of the nature of your relationship and so forth. But I think helping them realize that, he is as invested in her health and well-being, if for no other reason, because she is carrying his child. And as crass as that sounds, that that union and whatever it is, and whatever structure that relationship is, and however problematic it is, that you all are in this together. And so you got to figure out how to make this work from now. And if you're, as the pregnancy and child goes forward, you've got to figure this out. So no time like the present to start working through this, because you're stuck with each other now that you've made these choices.
And let me ask it from the professional side, because it's saying, how do we help them define it? So like Healthy Start, they're working with these dads. We have like some home visiting programs in Mobile. I mean, they're all over the state of Alabama, right? We have really seen a jump in programs that include fathers. So what is there more that we can do to help them, because they want to go beyond that? How else can we help them, expand their roles outside of, and get that off of their mind? Like, it's not all about that. I hear people say all the time, you're never going to be financially stable enough for a child. So just how do we help them understand that and take on, other roles and just, I guess, relax and just go with it. I don't know. Just bring up
Yeah,
those,
I mean,
those, like how they say mothers naturally know what to do. Let's help them naturally know what to do.
I think some of it can be from talking to other fathers. Like I think some of the I think we sometimes overcomplicate things. Like I'm not going to convince them. Me coming from out of the state and whatever that's not going to convince them. If they talk to other fathers and they are able to learn from them, look, man, I don't care how ready you thought you were, you ain't gonna ever feel ready, financially or otherwise. There's no book you're gonna read. There's no test you're gonna pass. Like no secret doc that's gonna give you access to information. It's not gonna happen. So, just you do have to learn. Part of what you're gonna have to learn in this role is how to roll with it and how to understand that you're never gonna feel prepared. You're never gonna feel ready, but you still have to sort of figure it out. And yeah, you're gonna. This is going to be a constant stressor. It's how do you deal with that stressor, and how do you make sure that you are still healthy and well in that process. That you can't forget your own health in that process. You still have to take care of yourself, because if your health starts to decline, then you definitely can't do anything of use to your child or to the mother. So you have to take care of yourself, and sort of that narrative. And that was part of why I started with the father and his health, is that if he's not taking care of it, he's not healthy and he's not paying attention to that. And often we don't. And that's, there is obviously all the data that shows that men tend to be sicker from chronic disease and die younger and all those kinds of things, which is why I study men's health and Black men's health. But we've got to change that and figure out what are the things you can do in that context that would actually help us to move forward.
All right. So more peer support and just, hey, and
giving them,
helping them to empower themselves. I also have a comment on that from someone. They're saying, they're speaking from a professional standpoint, also having OBGYNs encourage the woman to bring the father to the visits or invite them other than just the ultrasound. Be prepared with info for the father. So thank you for that, Maria.
Yeah.
Okay, last question, and then I'll have a comment. Short answer that he says, exactly how does the involvement of the fathers directly impact perinatal outcomes?
It could. I would think reduce the stress on the mother and on the body is the short answer. Yes.
Okay. And we have a comment. I think this is a good way to end it. Just they're saying wonderful to have a father's perspective included. As a dad's girl, dads matter a lot. So thank you. They're happy to have that support. And of course, all kids love their dads, All righty. Anyone else? They're still sending thumbs up and hearts and clapping for you. Thank you so much. They love you.
Thank you.
All right. Thank you, Dr. Griffith. We've enjoyed having you today.
Pleasure and honor. Thank you so much.
Here.
All right. Take care.
Okay. Remote. All right. Okay. Thank you to all of our staff, everyone that helped to plan this great summit, all of our partner agencies, everyone behind the scenes helping us with the technical details. We appreciate you all, our perinatal staff that helped us, our staff at Gift of Life, all our social workers, our staff at Healthy Start, Birmingham Healthy Start Plus, everyone that has had some involvement in planning this event, finding these awesome speakers, connecting us with them. We appreciate this. This is I think our 5th year hosting a summit. It's just great and engaging and enlightening, educational every time. We hope to be back in person next year. And thank you again all for participating, sitting here, being a captive audience for us. I do have a couple of more announcements. I've been putting things in the chat and I want to just make sure you get these 2 things, make sure you see them. Both of our agencies, all of our agencies, Healthy Start grantees and ADPH's MCH program are funded by HRSA. And so, of course, with that, there comes some things that we have to do, such as needs assessment, their evaluations of our programs. We're always trying to find out what our community has going on, any opinions that they want to share with us. And so we have a couple of surveys that are out right now. ADPH is having some listening sessions around the state, and you all as a community can join those and share your opinions. We also have a family survey out right now for our Title V MCH program. And I will send this to Mona so she can send it to you all. And so we need you all to respond to that and share your opinion so that we can ensure that the programs that we're implementing are beneficial to you all. Anytime you see something from any of us that's asking your opinion, please share it. We really do want to know. It does help us craft our programs, and we try to make things better for our community and our partners. So please take the time to respond to those. They're on our social media, on our website. You can find out more information. There's also going to be an evaluation of this event for today. As Mona mentioned earlier, there will also be evaluations for people who need CEUs. For the nurses, the social workers are good, but you'll get some emails about these evaluations that we are asking you to complete. Mona, is there anything else? Any of our other hosts, panelists have anything they want to share?
I just want to remind everyone that nurses have received the pre-test. You will the pre and post-test. You will receive the course evaluation form. All those 3 forms must be completed and emailed to me by September 14th. And that information will be provided to everyone who logged in and attended today. Social workers, you have nothing else to do. We'll pull your names directly from the Zoom attendees list and send you the social work CEUs. All others who wanted a certificate of attendance and indicated that, you will be sent that as well. You can also go to the Gift of Life website at golfound.org, and you can see video and copies of the presentation there. You can download them there.
And my last announcement before we end is please continue to check all of our websites, Gift of Life Foundation, Birmingham Healthy Start Plus, ADPH. We all have websites, social media, and we try to share events all around the state that are during this month. We'll be sharing events that are promoting infant mortality awareness. There are going to be some run walk events, there are candlelight visuals, there are presentations, there are community events, and we will post them on our social media just to spread the word. And this is for, we're not hosting these. This is any community event that I receive the information. If they have a flyer, if I get an announcement from the district MCH coordinators or a perinatal coordinator, whoever else, we post that because we want you all to be able to support these organizations and the great work that they're doing throughout the state. You know, no matter how large or small the community is, a lot of our things, yes, are based in Montgomery, Birmingham, Mobile, et cetera, but we are also always reaching out to smaller counties and communities. So please keep a watch for that and support those events throughout the month of September. Okay, if there are no questions and no more comments from any of our panelists, if you still have a question about CEUs, please email Mona. I still see someone saying they didn't get the pre-post test. Just email her. She will get back with you. Thank you all for the positive comments. I see the hearts and the questions and comments in the chat box and the horns and all that. Thank you all. Enjoy the rest of your day.